Good afternoon, everybody. I'm Dr. Pratik Tambe, Chairperson for the AMOX Endocrinology Committee, and a warm welcome to all of you, respected dignitaries and faculty assembled here today. Geeta Madam, can I request you to mute yourself, please? Yeah, thank you. Today's program for the AMOX Endocrinology Committee is with four societies of Jharkhand, namely Ranchi, Jamshedpur, Bokaro, and Dhanbad. And we welcome the office bearers of all these societies, the presidents and the secretaries who are joining us here today, or who will be shortly joining us within a very short period. We usually like to start by expressing gratitude to our office bearers of AMOX, Dr. Nandita Palchetkar, our esteemed president, who is the immediate past president of FOXI. Next slide, please. And Dr. Arun Nayak, the secretary of AMOX, both of whom are pillars and they have always been there for us whenever we have any academic activities or events. They're always there to support us and guide us. I must make a special mention of my zonal coordinator, Dr. Kedar Gandla, for his unflinching support for me over the years, over several years, I would say more than a decade. When I took my first steps in the Mumbai Society, Kedar was there for me today, even at AMOX. Dr. Arun Nayak, past president of Mumbai Society, who is now the secretary of AMOX, and Dr. Kedar Gandla, who is my zonal coordinator, are always there for me. Next slide, please. Minal, next slide, please. I'd like to welcome my co-convener for today's program, Dr. Geeta Sinha. She is the secretary of the Ranchi Society. She's done her post-graduation from Rajendra Medical College, worked in the health department at Jharkhand. She has her own hospital, which is Sai Sevayatan Hospital and IVF Center. She's previously worked in Saudi Arabia as a consultant. Currently, she is the secretary of the Ranchi OBGYN Society, founder of the Ramgarh Obstetrics and Gynecology Society, president of IMA Ramgarh from 2016 to 18, been chairperson of ISOPAB in 2019, and she's a very well-respected figure in the OBGYN circuit. At conferences and events, you will usually see her speaking, and of course, she's contributed immensely to a lot of public health programs, including cervical and breast cancer. Can we have the next slide, please? We are proud to have with us Dr. Mandakini Megh, the chairperson of ICOG, who's our chief guest for today. Madam has always been a very important figure for us in Mumbai as part of the Mumbai OBGYN Society, FOXI, as well as ICOG. And for her formal introduction, I hand over to my co-convener, Dr. Geeta Sinha. Madam, please unmute yourself. Please go ahead.
This is my pleasure that I
Ma'am, you are not heard. You need to unmute yourself, please.
unmute. It is already muted.
Yes, ma'am.
Can you hear me now?
Yes, ma'am.
So this is my pleasure that I have this opportunity to introduce Dr. Mandakini. Dr. Mandakini she is MD, DGO, FIC, MCH, FICMU, FICOG, chairperson of ICOG FOXI, International Vice President, MWIX Central Asia, Vice President, AMWI Central Council, National Vice President, FOXI 2012-2013, past President of Indian Federation of Ultrasound in Medicine and Biology, past Dean of Indian College of Medical Ultrasound, Chairperson of Imaging Science Committee, Director of Health Services, GOM, in charge of Family Welfare, RCH, PCPNDT, MTP and others, Advisor to Office on Special Duty, Family Welfare, GOM, Health Department, Mantralaya, Mumbai, prestigious post of Superintendent Kama and Alba Hospital for Women and Children in Mumbai from 1991 to 1995. Maternal health consultant for Government of Maharashtra, UNICEF, uh, awarded of DK Datta Best Publication Award in A category, Best Textbook, Foxy Publication, book of recent advances in postpartum care 2012-2013, awarded DK Datta Best Publication Award in B category, Best Textbook, Foxy Publication for the book Playing by the Rules 2014 to 2015. Dr. Ganitra Award of MOGS for Community Service on OB-GYN, recipient of Mahila Gaurav Puraskar of Government of Maharashtra 1996, recipient of MOGS Shalja Pandit Award for the working of women empowerment, domestic violence, contraception and family welfare, invited faculty for national and international conference, FOXY, FIGO, MWIA, IFUMB, seminars, workshops and world conference. Thank you. Thank you, ma'am.
Ma'am, you'll need to unmute yourself, please.
Yeah, it is unmute, ma'am. Sir?
Dr. Meg, madam.
Unmuted. Oh.
Dr. Meg, madam, please unmute yourself.
Yeah. Can you hear me now? Can you hear me?
Please go ahead.
Yeah.
Yes, ma'am. Yes, ma'am. Welcome.
Yeah. So, Pratik, thank you very much for organizing such a wonderful collaborative meeting with Jharkhand and Varanasi. I'm very, very happy that you are, doing a very good job. And I'm very happy that you are my governing council member for the next, governing council term. So thank you very much, Pratik, for inviting me. At the same time, I'd like to thank, organizing committee of Varanasi, organizing committee of Jharkhand, and to keep such program. I can see Pratik keeping all this program at, MOX, MPOC, so many collaborative this thing, and spreading knowledge is a tremendous work. I think, Pratik, next time you will be going to be a number 1 instead of number 2. And you have kept this subject of high risk pregnancy. I want to just say that ICOG is so committed to high risk pregnancy that we are doing so many programs. We are going to have this. We are going to have the program for the postpartum hemorrhages. We are going to have the programs for the this ultrasound in pregnancy, where we detect the prematurity and other things, and so many programs, certificate program we are keeping. But this particular program I like to say, because India is committed to achieve the maternal mortality and achieve the SDG goals by 2030, and we must all work towards it. And this is a very important step into the direction of achieving this reducing the maternal mortality. I'm hoping that so many faculties, international, national faculties are there. They are going to give a lot of nice scientific deliberation, and all the viewers here, they are going to actually benefit from this. And I think with this, I again congratulate Dr. Pratik, all the organizing committee, all the viewers and all the speakers. Please go ahead. It's going to be a wonderful meeting for all of us. Thank you, Pratik. And thank you, everyone. Thank you, Bibanita Sai, for inviting me. Thanks a lot.
Thank you, Dr. Meg, madam, for those beautiful words of wisdom. Minal, can we have the slides back up, please?
Pratik, you could hear me, na? Because
yes, ma'am, loud and clear. Thank you so much.
I was on a iPad first time.
No, ma'am, it's absolutely fine. After the first few seconds, it was absolutely fine. Can we have the chairperson slides, please? I take great pleasure in introducing our first chairperson for today, Dr. Rajendra Singh Pardeshi, Vice President of AMOGS. We are privileged to have Sir with us today because he is very busy and usually it's very difficult to get him to come to a webinar, even if it's for a few minutes. Thank you so much for joining us, Sir. Sir has won 6 times the Best Paper Award at Foxy's AICOG conferences, has been faculty on multiple occasions at international events as well. He is a past chairperson of the Foxy Food, Drugs and Medical Surgical Equipment Committee from 2012 to 14. He's past vice president of Foxy last year when Dr. Nandita Palshetkar madam was the president. And now the same team is also in charge at AMOGS. Dr. Nandita Palshetkar is the president of AMOGS and Dr. Pardeshi sir is the vice president. Welcome, sir. Can we have the next slide, please?
Thank you.
Dr. Geeta Sinha.
I got the opportunity to introduce Professor Maya Verma, my president of ROGS. She is ex-professor OB-GYN Department RMCH Ranchi in year 2001, retired professor and HOD Ops and Gynae, Government Medical College, Haldwani, Uttarakhand, year 2008, the president of ROGS, Ranchi Ops and Gynae Society, Ranchi, Jharkhand, keenly concerned with the social welfare work with different NGOs, current participating as a senior consultant OB-GYN at Ranchi. Thank you. Ma'am, welcome, ma'am.
Next slide, please. We are privileged to have with us Dr. Banita Sahai. She is currently She is the president of the Jamshedpur OBGYN Society. She's had multiple presentations in conferences. She also has a research paper in International Journal on CA cervix and hypothyroidism. Currently works at the MGM Medical College and is the director of Sahai Clinic and R&D Center. President of the Women's Wing of IMA. She's organized fertility conferences with ISAR and ICOG in November 2019. Also organized Beti Bachao Symposium, participated in AICOG 2020 as a panelist on liver diseases. Welcome, Dr. Banita Sahai. Next slide, please.
Dr. Kaushik Das. I welcome Dr. Kaushik Das. He is MBBS MS endoscopy from Germany and FIAOZ. Awarded the Best Outgoing PG Student 2003. First prize in Young Scientist Paper Award at Annual BOG Meet Bokaro 2003, Best Paper Award at East Zone Yuva Foxy Ranchi 2004, recipient of Vidya Vasin Award 2008 at the Indian Society of Perinatology and Reproductive Biology, was organizing secretary of 6th AOGSBJ conference, conducted live USG workshop at various state and national level conferences, presented original paper in FICO and SAFOG internationally, consultant in high-risk pregnancy, gynec endoscopy and ART IVF at Surgery Center Bokaro. Presently at the President of Bokaro Obstetrics and Gynecological Society. Welcome, Dr. Kaushik Das, please.
Next slide, please. Dr. Kavita Priya is the Deputy CMO of the Central Hospital in Dhanbad. She is also the President of Dhanbad OBGYN Society, organizing secretary for the 4th annual conference, which was held there, organizing chairperson at the 5th annual conference of Dhanbad in 2019. She is faculty and speaker at several conferences, and she is a very well-respected figure in Jharkhand. Welcome, Dr. Kavita Priya. Dr. Geeta Sinha and myself will now recede to the background. We hand over the stage to the chairpersons, and we would request you to introduce our first speaker for today, none other than Dr. P.K. Shah, our past president of Foxy, a very legendary figure in OBGYN in India. We are privileged to have Sir with us today. He's been a past president of the Mumbai Society, IAG, Foxy, so many other organizations. Reading his CV will take 10 minutes. And Sir will have a little time to speak after that.
Don't read it. I can talk for 5 minutes more.
Can we have the slide of Sir's introduction, please? Meena,
Hi,
you need the
Rajendra.
CV for Dr.
Sir,
PK
namaskar.
Shah.
नमस्कार. राहू दे रे.
सर तुमचं सीव्ही आम्हाला चांगलं वाटतं.
अरे किती वेळा वाचायचं रे.
आम्हाला ऑनर मिळतो तुमचं
Meena
सीव्ही
and
वाचणं.
Sana, we need the
मॅडम
CV
मेघने तर
slide
कान
of
सुद्धा बंद
Dr.
केले.
PK Shah, please.
नाही कान बंद नाही केले मी पक्का
I know.
केला की पक्का केला की
Even I have the earphones. I have to keep doing that.
doing that. So I
प्रत्येक
can
मी वाचतो
introduce.
सरांचा
I can
तुम्ही करा.
introduce Doctor. I can introduce Dr. PK Shah. Nobody can introduce Dr. PK Shah than what I can do. So our Dr. PK Shah, very legendary figure. He's a very well known as a past Secretary General for so many years. Very experienced person. Past Oxy president, past MOGS president, then the past IPMB president, past dean of the Indian College. He is a past editor of IPMB, co-editor of the OBGY journal, member say for the Motherhood Committee FIGO. He has got many publications, and most importantly, he was the faculty and head of the KEM Hospital and SET Medical College, and we can see many of the students, including Dr. Rajendra Pardesi here, who is one of his students, and I had the grand privilege of working with Dr. PK Shah as a vice president of the TOG. We had a wonderful time, and actually we did a lot of work in the TOG. With this small introduction, I present to you Dr. PK Shah.
Thank you very much, ma'am. I think it's a rare thing that a chief guest introduces a speaker. Thank you so much.
And there is
Sir,
Thank you
nothing
so much.
between you.
our biodata will not be completed.
Can I share the screen now?
Yes, sir, please go ahead.
Okay.
We are due to Dr. PK Shah and our
Thank you.
data.
Thank you, Dr. Rajendra Singh Pardesi. Thank you. Now, at the outset, let me thank AMOG's Endocrinology Committee Chairperson, Dr. Pratik Tambe, Dr. Nandita Palshetkar, Dr. Arun Nayak, and all the presidents and secretaries of Jharkhand OBGYN Society for giving me this opportunity to talk to you on management of rhesus-negative pregnancy. I'm very happy to share this platform with Dr. Parag Giniwale, and I'm really proud to have Dr. Mandakini Meg as today's chief guest. So, before much of ado, let me start. That's the CV which you already seen. The outline for my talk would include introduction, epidemiology, pathophysiology, management, problems in our setting, recommendations, and conclusions. We all know that in 1940, Landsteiner and Weiner introduced for the first time Rh antigen, and 1 year later, the Rh antibody were found by Levin et al. The incidence of Rh negative women getting pregnant in India is around 4.6%, Chinese 1%, blacks 7.8%, European 15%, and Basques 30 to 35%. What is isoimmunization? It's a production of immune antibodies in an individual in response to an antigen derived from another individual of the same species, provided first one lacks that antigen. It occurs in two stages. First stage is the sensitization, and the second stage is immunization. The incidence of isoimmunization luckily is low due to avio incompatibility, which confers protection against Rh antigen. Critical sensitizing volume is 0.1 milliliter only. Unfortunately, inadequate placental transfer of immunoglobulins, and there is something called as Rh stimulus non-responders. And so out of 100 Rh negative women, 30 will not respond to Rh positive fetal cells. And there is difference in immunogenicity of different antigens. We all know about the blood groups, that if you have a blood group A, you have A antigen and B antibody is present in your body. If you have a B blood group, then you have B antigen and you have A antibody in your blood. If you are AB, then you have A plus B both antigens and no antibodies in your blood. And if you are O, then you have no antigen, but you have A plus B both antibodies present in your body. AB blood group people are universal recipient, and O blood group, they are universal donors. When you come to rhesus system, it is capital C, small c, D. Mind you, there is no small d. I'll come to that. E, capital E, small e, and G. There is no small d antigen. When you write small d, it represents absence of second allele of D. Normally you have two, either DD, both capital. But here when you write D, it means that's a capital D. It means there is an antigen. And if you write small d, that means there is no such antigen. The D antigen is considered to be the most immunogenic Rh positive factor. Now, D antigen, as we already said, is most immunogenic. There are about 85% people are Rh positive, and out of this, homozygous will be having both alleles of capital D. They are 35%, whereas heterozygous will have capital D and small d, that is 50%, whereas Rh negative, that means no D antigen at all, are 15%. We all know that the placenta usually acts as a barrier to fetal blood entering the maternal circulation. But when this barrier is broken by feto-maternal hemorrhage, you can have antenatal sensitization in 10% and postpartum in 90%. What is the risk of immunization? In first trimester, it is about 3%, second trimester, 12%, third trimester, 46%, and intrapartum, 50 to 55%. You have feto-maternal hemorrhage less than 0.1 milliliter in almost 50% during labor, whereas more than 30%. Spontaneous abortion, the risk of 2 to 3% of getting isoimmunized, and therapeutic abortion 4 to 5%. Try and understand this particular picture, that when you have this particular Rh positive father, he has only one copy of capital D. The partner has no copy, she is Rh negative. So when they have children, they will have half of them having Rh positive and half of the children, number of children, they will have Rh negative. Whereas if you have a partner who has two copies of capital D genes, the RhD genes, that is homozygous Rh positive father and Rh negative mother, they all, because one comes from here, because both are capital D, each and every child will be Rh positive. Feto-maternal hemorrhage and Rh incompatibility. Rh alloimmunization occurs by one of the two mechanisms. Number one, after incompatible blood transfusion, if Rh negative mother is transfused Rh positive blood, or after feto-maternal hemorrhage between mother and the fetus. Notwithstanding, fetal RBCs have been detected in maternal blood in all three trimesters, in 7%, 16%, and 29% in first, second, and third trimester respectively, without an apparent predisposing factor. The initial maternal response to Rh sensitization is low level of immunoglobulin IgM antibodies. These IgM antibodies are confined to maternal circulation, only being unable to cross the placental barrier. But after that, within 6 weeks to 6 months, the IgG antibodies are formed, and these are able to cross the placenta and destroy the fetal Rh positive cells when they go to the fetus's body. Therefore, firstborn infants with Rh positive blood type are not affected. The short period of first exposure of mother to fetal Rh positive RBCs is insufficient for production of significant IgG antibody response, and that's why most of the primates who are Rh negative and are having Rh positive fetuses, they escape. Now, what happens to the baby? The hemolytic disease of the newborn, the sequence of in utero events, that you have maternal IgG antibodies, they enter the fetal circulation via placenta and destroy the fetal RBCs. That causes fetal anemia because the RBCs are destroyed. And when you have the hematocrit less than 30%. When you have destruction of RBCs, the heme molecule is formed, and it is ultimately converted into bilirubin, and that causes fetal hyperbilirubinemia. Both are neurotoxic, but effectively they are cleared by the placenta and metabolized by the mother. Extramedullary erythropoiesis is stimulated, that causes hepatosplenomegaly. Immature erythroblasts are manufactured. When cell destruction exceeds production in the fetus, severe anemia occurs in the fetus in utero. There is more demand on extramedullary sites to produce more and more RBCs, that causes hepatosplenomegaly. Heart failure eventually results with ascites, edema, and pericardial effusion, and that condition is called erythroblastosis fetalis, and you can have ultimately hydrops fetalis when the hematocrit falls below 15%, often results in fetal death shortly before or after the birth. The male to female fetus affected, the ratio is 13:1. Now, not only the baby suffers, but the mother can also have problems when she is sensitized with Rh positive blood. That is, she can have increased blood pressure, mild edema, albuminuria, polyhydramnios, postpartum hemorrhage, and DIC. The risk and severity of sensitization response increases with each subsequent pregnancy involving an ABO-compatible fetus with Rh positive blood. Without prophylaxis, the risk of sensitization goes to 16% after 2 deliveries. 1.5 to 2% occur during antepartum period, 7% within 6 months of delivery, and 7% manifests early in second pregnancy. With prophylaxis, this risk drops to 0.1 to 0.2%. If you give only postnatal NTD injection after delivery, then the risk comes down to 2%. From 16%, it comes down to 2%. And if you give antenatal plus postnatal NTD prophylaxis, then the risk comes down to almost 0.1 to 0.2%. Aforementioned risk depends on three main factors: the volume of the transplacental hemorrhage, extent of the maternal immune response, and concurrent presence of ABO incompatibility, because it is very protective and the risk drops to 1.5 to 2%. Rh incompatibility is only of medical concern for females who are pregnant or plan to get pregnant in future. Now, you must go into the details and find out what is the history. There is a history of potentially sensitizing event like abortion, spontaneous or induced, invasive procedures like amniocentesis, chorioangular sampling, abdominal pelvic trauma, antepartum hemorrhage, placenta previa or abruption, intrauterine fetal demise, multiple pregnancy, manual removal of placenta, ectopic pregnancy, C-section, etc. How do you manage this patient antenatally? Other aspects of history to be explored include prior blood transfusion, whether she has been given blood for any indication, Rh blood type of patient, and spouse, very important. All previous pregnancies, outcomes, and interventions, if any, should be looked into. If there is a history of delivery of hydrops in past, there are 90% chances that she will have recurrence of hydrops in next pregnancy. Find out what the previous administration of Rh IgG was given to her or not. When was it given? During antenatal or postnatal period? Mechanism of injury in case of maternal trauma during pregnancy. Presence of vaginal bleeding and any invasive procedure that was carried out in the past. What is the objective of antenatal management? Basically, it is to prevent the Rh immunization, Rh negative unsensitized woman, and early detection and treatment of anemia in sensitized women. Sensitization is determined via the indirect Coombs test that we all know very well. Don't try to read this. I will read it out for you. If you have a mother who is Rh negative and the father who is Rh positive, do maternal antibody screen, that is indirect Coombs test, ICT, at 20th week, 24th week, and 28th week of gestation. If the ICT is negative, give a 300 microgram of NTD injection at 28 weeks. And When she delivers, give again NTD if the baby is RH positive. If the baby turns out to be RH negative, no further treatment is required. Now, when you are doing indirect Coombs test, if it is positive, manage the RH sensitized pregnancy. You can do amniocentesis for estimation of fetal bilirubin level at optical density 450 nanometer. If you do not have facilities of doing MCA, peak systolic velocity in your place. But ideally, we should do Doppler ultrasound of middle cerebral artery and see what is the peak systolic velocity. If the antibody screen is negative, ICT is negative, it is repeated monthly from any time she registers at your place after 20th week till 28th week, and give her antenatal prophylaxis. What is this RAADP? Routine antenatal NTD prophylaxis is called RAADP. It is NTD immunoglobulin intramuscular injection at 28 weeks of gestation, given on deltoid and not in gluteal region. Please remember this very clearly. It is a polyclonal derived from human plasma that is given and not monoclonal, though they are available. There are intravenous preparation like Winro, SDF also are available whenever you have large feto-maternal hemorrhage. Take consent of the patient. If she refuses, document it on paper. If she sensitized woman, you can't give NTD, it doesn't help. And avoid giving her any live vaccine at that point of time when you are giving this. What about NTD IgG choice of preparation? It's always polyclonal. I will not go into the details because of constraint of time. What are the SUG guidelines? That if you have RH negative woman, non-immunized, that means ICT negative, indirect Coombs test negative at 28 weeks, give her NTD injection 300 microgram. If it is abortion less than 12 weeks, 50 microgram, abortion more than 12 weeks, 300 microgram, and any other event which we already discussed warrants use of RH NTD 300 microgram. Now, there are groups of people who say that irrespective of what is the period of gestation, whether it is less than 12 weeks or more than 12 weeks of abortion, spontaneous or termination of pregnancy, give 300 microgram because you don't have 50 microgram available. So don't waste the rest of the NTD. Postpartum, within 72 hours of delivery, give her 300 microgram if baby is RH positive. If delivery occurs within 3 weeks after the administration of antenatal RH NTD at 28 weeks, repeat the dose. Repeat dose is unnecessary unless large feto-maternal hemorrhage occurs. I hope it is very clear. We are given at 28 weeks and she delivers within 3 weeks of giving this antenatal NTD. Do not give repeat dose. You can give NTD following molar pregnancy if it is partial mole and not if it is complete mole. What are the risks of NTD immunoglobulin? You can have risk of fetal anemia, enhancement of maternal primary immune response, DV positive RBCs, adverse obstetric outcome. But read the last line. There is no evidence that maternal administration of NTD immune globulin results in any significant risk. How do you manage large feto-maternal bleed? Do a rosette test, whereby you have a maternal blood plus NTD plus indicator RBCs with RH antigen. If rosette is formed, that means rosette test is positive, measure percentage of fetal cells by Clio or Betke test or flow cytometry. Give additional NTD 10 microgram for every 0.5 milliliter of RBCs circulating in mother circulation. Screen positive women should not receive NTD injection. Please remember this very clearly. It is not effective once alloimmunization to the D antigen has occurred and even will not prevent a rise in the maternal titer. So do not give NTD injection if she is ICT positive or screen positive. What are the precautions during delivery? Ensure consultation with neonatologist. Don't give oxytocin at the delivery of anterior shoulder of the baby. Manual removal of placenta if required. Do it gently. If blood transfusion is indicated, use compatible RH negative blood only. Early clamping of the umbilical cord is indicated and leave a long length of cord about 50 to 20 centimeter in case the exchange transfusion is required by neonatologists. Postpartum management includes involving the neonatologist, obviously, send cord blood samples for ABO, RH typing, hemoglobin, direct Coombs test, bilirubin, peripheral smear, etc. We all know that. If fetus is RH negative, no further intervention, no NTD, nothing. If fetus is RH positive, determine the dose of NTD injection to be given, and you can administer it by a 4-step lab procedure, which will come to very shortly. To summarize, I have not finished my talk. It is only the non-sensitized pregnancy. To summarize it, RH-D negative pregnant women always do husband's RH-D status. If he is RH positive, that means RH-D positive, mother's indirect Coombs test should be done. If the indirect Coombs test is negative in first visit, repeat every 4 weeks indirect Coombs test. If it remains negative at 28 weeks, give her NTD injection 300 microgram, deliver her at term, and give immediately after delivery within 72 hours NTD again 300 microgram. Now, what is this 4-step lab procedure? You can do a rosette fetal RBC screen for fetal-maternal hemorrhage. If the test is positive, go for acid elution, or what we call Clear-Betke test, KB test, to quantify RBCs in maternal circulation. Estimate the volume of fetal-maternal hemorrhage and calculate the dose of RH IgG to be given within 72 hours of delivery. On the left side, you see negative result, the rosette test, and on the right side, you see that rosette formation within the peripheral smear. Once that is positive, go for Clear-Betke test, and this will be positive if you see this sort of dots. For sensitized women, management is guided by following: presence or absence of history of affected fetus in previous pregnancy, whether there was a severe anemia or hydrops or not, maternal antibody titers when there was no prior history, and the sensitization may be determined by doing antibody screening using indirect Coombs test. What are the causes of alloimmunization? She might be pregnant earlier on and nobody gave her NTD, or inadequate dose of NTD was given when there was more fetal-maternal hemorrhage. Antenatal proxylytics is not given. Unrecognized fetal-maternal hemorrhage. Postpartum dose given after 72 hours. Patient already immunized, but the antibody titer is too low to be detected by in a lab, and a defective NTD injection given. This is a direct Coombs test from mother blood, and this is from the cord blood that we obtain when the baby is delivered. We can do, this is the indirect Coombs test, and that is the direct Coombs test. Now, how do you diagnose fetal anemia? There are two ways: non-invasive by ultrasound and Doppler MCA, Doppler of middle cerebral artery, peak systolic velocity. There is no risk of fetal loss when you go for non-invasive, and there is no risk of exacerbation of hemolysis, which can happen when you do chordocentesis, amniocentesis, etc., which are invasive methods. What are the features of severe anemia on ultrasound? Hepatosplenomegaly, hyperplacentosis, thick placenta, polyhydramniosositis, pleural effusion, thickening of the skin, and in absence of eye drops, ultrasound cannot distinguish mild form from severe disease. Absence of these findings, as above, cannot exclude anemia. Please remember that. Now, how do you manage a sensitized RH negative woman? We talked about earlier on non-sensitized, but now she is ICT positive. There is no previous history of affected fetus. Obtain the ABO and RH group of the husband. That is always has to be done if you have a RH negative woman coming to you during pregnancy. If the RH group of husband is positive, obtain antibody titer from the mother. If antibody titer is below critical level by 36 weeks, continue pregnancy till term, but not allowed to go post-dated. Please do not allow this pregnancy to go beyond 40 weeks. Now, If antibody titer is beyond critical level and after 34 weeks, deliver her. If antibody titer beyond critical level but pregnancy is before 34 weeks, there further testing is required. Do middle cerebral artery peak systolic velocity and see what is the peak systolic velocity. Or you can do amniocentesis for analysis of spectrophotometry and bilirubin level and ultrasound examination of the fetus. And lastly, percutaneous umbilical cord blood sampling for hematocrit and hemoglobin. If there is a previous history of affected fetus, establish the sensitization. You can do chordocentesis and obtain the blood for hemoglobin and hematocrit, etc. You can do either amniocentesis or bilirubin level, and the best of all would be to do middle cerebral artery peak systolic velocity. So there is a fetal assessment of hemolysis by invasive procedure which we used to do once upon a time, like amniocentesis and fetal blood sampling are given up literally. Out of 100, say 80 patients, you will not require it. You will go only for middle cerebral artery. So, why middle cerebral artery Doppler? That accurate and non-invasive screening tool for detection of moderate to severe fetal anemia, a sensitivity of 100% and 12% false positive rate for anemia. Use has resulted in up to 80% reduction in invasive testing like amniocentesis and chordocentesis. But why middle cerebral artery and not any other artery? In response to fetal anemia, there is increase in fetal blood velocity in various vessels due to increased cardiac output and decreased blood velocity. And the middle cerebral artery is most visible and it's easily can be picked up on transabdominal sonography when you are taking the biparietal diameter, come down below that slightly, put on color, see the circle of Willis, and you will be able to see the middle cerebral artery. Mari et al. Was the one who started study of middle cerebral artery peak systolic velocity way back in 2000. According to Mari, the sensitivity was almost 100% and 12% false positive. When do you call it epithelia? When the hematocrit is less than 30%. Middle cerebral artery Doppler velocimetry is not useful before 18th week of gestation or even after 35th week of gestation. It's not a reliable predictor of severe anemia. Why is it not useful before 18th week? Because reticular endothelial system is too immature to hemolyze enough cells to cause significant anemia. It is found to be similar or better than amniotic fluid optical density at 450 nanometer in prediction of anemia. So that is the reason we have given up amniocentesis in these cases of sensitized pregnancy. When and how frequently? Start at 18-20 weeks and it is useful up to 35th week of gestation. It can be repeated anywhere from 4 to 14 days depending on previous history and the prediction zone in which the anemia level is. So, how do you use MCA-PSV for diagnosis of fetal anemia? That if you have the peak systolic velocity more than 1.5 MOM multiples of median, and if the gestation is less than 35 weeks, do chordocentesis. See the trend. If the trend is normal, induce labor at 38-39 weeks. Nothing else required. If the gestational age is more than 35 weeks and the peak systolic velocity is more than 1.5 MOM, then again go for the repeat trend and see what is the trend. If the trend is normal, induce at 38-39 weeks. But if it is rising, the mean middle cerebral artery peak systolic velocity keeps rising, then do lung maturity, give her steroids followed by induction of labor. And if the middle cerebral artery peak systolic velocity is less than 1.5, Then do sequential middle cerebral artery peak systolic velocity every week or 2 weeks. I hope it is clear. Normally, say 24th week of gestation, if you see the peak systolic velocity, it would be double, 48 centimeters per second. At 28 weeks, it would be 56. Now, if it is more than that, you know it is abnormal. And that is how you can roughly calculate. But you have to find out MOM, multiples of median. The picture on the left shows you the picture on the right shows you a very high peak systolic velocity, very high in this, more than 70 centimeters per second. What are the results of MCAD velocimetry? If it is unaffected or mildly affected fetus, Doppler is repeated monthly and delivery near term after lung maturity. There is very low risk of intrauterine fetal death. Moderately affected fetus, middle cerebral artery Doppler 1.5 multiples of medium, repeat 1 to 2 weekly, deliver after lung maturity, enhancement of lung maturity may be required. If it is severely affected, you will find middle cerebral artery peak systolic velocity more than 1.55 MOM or has frank evidence of fetal hydrops. Fetus needs help to attain lung maturity before delivery, and there is a high risk of intrauterine fetal death. I am sure Madam Mandakini Meg would remember Liley's and Queenan's chart that we used to follow once upon a time, but that can be used now with even middle cerebral artery PSV to find out the trend so that you know what to do next. What are the risks of isoimmunization? If you do not give any NTD, 12 to 13%. Only postnatal NTD, 1 to 2%. And antenatal plus postnatal NTD, we know it is around 0.1 to 0.2%. What happens when you have a first isoimmunized pregnancy, which is not common, but suppose you have ICT positive and the titer usually are low. Severe fetal anemia may not develop or develops late in pregnancy compared to subsequent pregnancy. Indirect womb test should be done monthly, and if there is a rising titer, repeat every 2 weeks. Critical titer is one that is associated with risk of development of severe anemia and hydrops, that is 1 in 16 or more. If you have 1 in 16 or more, monitor anemia by again middle cerebral artery peak systolic velocity. If the middle cerebral artery Doppler velocimetry peak systolic velocity 1.5 millimeter MOMs or above, then you can do fetal blood sampling, and if there is no facility, you can do amniocentesis. If the middle cerebral artery PSV is less than 1.5 MOM, monitor 1 to 2 weekly. Now, how do you manage this baby who is having more than 1.16 titer? Intrauterine blood transfusion is recommended. Treatment for severe hemolytic anemia in utero, typically carried out between 18 to 35th week of gestation, may be given intraperitoneal or intravascular. ORHD negative packed cell with hematocrit of 80% is used. Amount to be transfused is calculated in milliliter. That is what is gestation age. Say it is 28 weeks. Then minus 20 from that. So it is 8 multiplied by 10. That means 80 cc when the gestation age is more than 20 weeks. What is the aim of intrauterine transfusion? To raise the hematocrit of the fetus to almost up to 50%. Amount to be transferred depends on the fetal hematocrit, estimated fetal weight, donor blood hematocrit, volume of blood to be transfused, and as low as 10 milliliter and as high as 110 milliliter can be transfused in a single go. What are the prerequisites? You must take a consent, high resolution ultrasound, experts team, accessible target, facility for blood group, hematocrit transfusion, etc., fetal monitoring, steroid cover, emergency obstetric services, and NICU. Post transfusion fetal monitoring, you must do ultrasound and do MCA PSV. Why? Because you must decide when to give next transfusion. How do you find out? The fall of hematocrit occurs by 1% every day. So you know what was the hematocrit post transfusion, and accordingly you can give the second and third transfusion. Also, you have to do fetal well-being monitoring. You must decide the timing of delivery. When should be the last transfusion given? around 35 weeks, not beyond that. If less than 34 weeks, give steroids and then deliver. Decide whether you have to go for C-section or vaginal delivery, depending on whether there are indications for C-section or not. What are the complications of intrauterine transfusion? Overall, 3.5% fetal loss, 1.5 to 1.7%, and it could be because of cord hematoma, bradycardia, and emergency LACS required. This is how you do the intrauterine blood transfusion. The sensitized Rh negative woman, postpartum management of neonate, the baby, if alive, should be admitted in NICU. Urgent extended blood transfusion is indicated in moderate to severely affected neonates, and phototherapy may be required for mild affection. If you have abortion, invasive fetal procedure, antepartum hemorrhage, external cephalic version, give all these patients 300 microgram. Now, what are the recent advances? That when you have a non-invasive fetal RHD genotyping from fetal cell-free DNA in maternal circulation, if you know what is the genotyping of husband's blood group, yes, or fetal blood, you know what is the genotype, whether it is RHDD, capital, both capital D or small d, and one capital D, etc. in the husband, then you know whether the baby is going to be Rh negative or Rh positive. There is something called the point of care test, POCT, which is rapid test for determining Rh status. A lower 50 microgram dose preparation of Rh IgG for following first trimester abortion. Where it is not there, we normally give 300. Concept of partial D and weak D antigens usually test positive, but can also be from anti-D, anti-Rh antibodies. What are take-home points? Early woman of childbearing age should have, every woman of childbearing age should have her blood group ABO and Rh type done at first contact. Obtain the ABO Rh type of husband or woman found to be Rh negative. Ensure that the indirect Coombs test is done at 20, 24, 28 weeks of pregnancy with appropriate prophylaxis. A single postpartum dose may be inadequate in cases of severe fetal-maternal hemorrhage. What are the problems in country like ours? That we have a very high cost of immunoglobulin, lack of resources to adequately investigate and monitor fetus in utero, low turnout of antenatal clinics, so we miss out the cases who are Rh negative, poor documentation of prior sensitizing events, some are yet to be fully grasped the importance of it, and you can have loss of case notes. So what are the recommendations? Advocacy for partnership by Government of India and NGOs to help subsidize the cost of immunoglobulins, special insurance cover for Rh negative women, ensure case of procurement when needed. There has to be ease of procurement. Involvement of clergy as a part of premarital counseling, which is hardly seen. Creation of special fora or group for Rh negative people who are potential Rh negative spouses also can meet. To conclude my talk, ladies and gentlemen, rhesus immunization is a real problem and real efforts need to be made to mitigate its importance. Although its incidence has decreased dramatically, yet the consequences of hemolytic disease of the newborn remain. Great advancements have been made in the detection and management of this condition, and many of our Rh negative women can now have happy obstetric care. Thank you very much, ladies and gentlemen, for your patient hearing.
Thank you, sir. It was a very nice and elaborate lecture on Rh immunization. To hear again is really a pleasure for us. We are really humbled and we are feeling obliged to have such a elaborate and informative lecture on Rh immunization. Thank you so much, sir.
Thank you.
Dr. Pardeshi, sir, any comments?
It was really a nice academic feast by Dr. Pikesha. Pikesha is always best, and when I will get chance, I will still hear his talks in all talks. Not only sonography, but on preterm labor and like this all.
Every time we listen to sir, we learn something new.
Yeah. Even I learned something from all of you.
Yes. In this talk also, sir has added all the procedures invasive procedures, ICT and all that, intrauterine transfusions and all that. It was a very nice talk, sir.
Thank you so much. We'll proceed to the introduction of the next speaker, Dr. Parag Biliwale, requesting the chairpersons to please introduce her formally.
Should I? So, yes. Madam, you can continue, madam. Yes.
Hello.
Yes.
I am Dr. Maya Verma. Before I want to say one thing. Before I introduce Dr. Biniwala, I would like to bow my head to before Dr. P.K. Shah, for I am seeing him for the very long period, and I have just now heard about the all qualities you have mentioned. Dr. Mandakini has told, and he may not be knowing me, but whoever is the member of Foxy knows him very well. So especially I am taking the time for bowing my head and rendering pranam to him.
Thank you very much, Dr. Maya Sharma.
Verma, sir, I am Verma.
Yeah, Maya Verma.
I met you when you came to Ranchi. Besides all the quality, you're so loving person, talking to every person who is very at the lower level, at a higher level, and at your level. I don't know who are at your level, but you were
Foxy, all of us are same level.
So no. Your knowledge cannot be equal to me. I cannot dare to become your level.
No. It's not
so
like that.
Good noon, sir, and again pranam.
Thank you so much.
I'm rendering good noon to Dr. Pratik and Dr. Mandakini and all our viewers. And now I will introduce Dr. Parag Biniwala. So, hello, Dr. Parag Biniwala. Good noon. Dr. Parag Biniwala is the consultant of obstetric and gynecology in Pune. He is the unit head and PG teacher at Kamla Nehru Hospital, Pune. He is secretary of ICOG. And he was the president of Menopausal Society, Pune. He is the National Joint Secretary, IMS, in 2017 to 18. He is National Website Editor of Foxy from 2011 to 17. So many quality. He is the viewer of Journal of Obs and Gynae of India. Is the chairperson of Young Talent Promotion Committee of Foxy, and he is the master trainer of adolescent friendly health services also. He has conducted so many workshops for WHO and UNFPA and Foxy. Co-editor of Gynecological Manual, has contributed the articles in the many books and journals. He has delivered orations, guest lectures in over 120 Foxy societies. Such a great thing. He is also a recipient of Dr. C.S. Down Prize at 51 All India Congress of Obs and Gynae at Delhi. So welcome, Dr. Biniwala. You are having so many qualities, has attended so many committee also and guided. And the best of is the Adolescent Health Society. So welcome, Doctor.
Thank you. Just add to Dr. Parag Biniwale and Dr. Mandakini Meg, these two persons, and they made ICOG, the recognition of ICOG, and they are helping each and every Foxy members for this academic wing. And not only that, but every people, when society, they are applying for accreditation, they are always helping them, they are guiding them, what are the mistakes and what are they, even in Foxy, ICOG, small things, how you become a member, every time they are helping them. So thank you, Dr. Beniwal and Dr. Mandakini Meg, ma'am.
Thank you. Thank you, Dr. Maya, for this kind word. Good afternoon, all. I bring greetings from ICOG, Indian College of OBGYN, which is the academic wing of Foxy. Thank you, team AMOGS, Dr. Nandita, Dr. Pratik, and all the office bearers of AMOGS for inviting me here. And it's a pleasure to be in front of Jharkhand OBGYN societies. I have fond memories of visiting Jharkhand way back in 2010 for assisted vaginal delivery workshops. but it's a difficult task to speak after legendary Dr. P.K. Shah, who's mesmerized all of us with his deliberations on Rh negative pregnancy. Now, in next 15-20 minutes, I'm going to talk about another challenging problem in our country, and that is gestational diabetes. Hyperglycemia in pregnancy is one of the most common medical conditions in women who encounter during pregnancy. And it is estimated that 1 in 6 live births occur to women with some form of hyperglycemia, and 84% of which are due to gestational diabetes mellitus. Hyperglycemia is usually associated with increase in maternal morbidity and mortality. There is higher incidence of perinatal and neonatal morbidity, and we must not forget the long-term consequences for the mother as well as for the child. It is estimated that 127 million live births take place in the world. India, China, etc. contribute to almost more than 50% of births all over, out of which 21 million women or 21 million pregnancies every year are complicated by hyperglycemia. But unfortunate part is only 3 to 4 million are detected and treated, and hardly any receive postpartum follow-up and lifestyle advice. So when we talk about hyperglycemia in pregnancy, we are dealing with two situations, that is diabetes in pregnancy and gestational diabetes mellitus. What is the difference? Gestational diabetes mellitus is hyperglycemia, which is diagnosed for the first time during pregnancy, and it may occur anytime during pregnancy, but most likely after 24 weeks of gestation. How common is the problem? Foxy and Dipsy have estimated that 1/3 of pregnant women may be suffering from gestational diabetes. 33% in the first trimester, 40% in the second trimester, and 28% in the third trimester is what the government of India says. But why are we so much concerned about gestational diabetes? And that is because of its effects on the mother as well as to the fetus. So what are the maternal issues that are brought in by gestational diabetes? Women can land up with spontaneous miscarriage in early pregnancy. When the pregnancy continues, women are at more risk for preeclampsia, gestational hypertension, recurrent urinary tract infections, macrosomia, and hydramnios. Delivery is difficult in these women. Women are more prone for preterm births. More instrumental deliveries or more traumatic deliveries are noted. Chances of resulting in a C-section is a known possibility. Women do develop postpartum infection, PPH. In short, women are more prone for morbidity and in some situations even mortality. Puerperium is also stormy, where women are bothered by infections and lactation failure, and we must not forget the long-term postpartum consequences, which would be weight retention, GDM in subsequent pregnancies, development of diabetes mellitus, and coronary vascular diseases. The neonate or the child is also not spared. We do have higher chances of stillbirths, neonatal deaths, congenital malformations, especially if the sugars are not well controlled in the first trimester. Babies are more prone for shoulder dystocia, RDS, cardiomyopathy, hypoglycemia, hyperbilirubinemia, and so on and so forth. In short, the babies are more prone for something called FOAD, that is fetal origin of adult disease. So what is very, very important is to screen women to detect presence of gestational diabetes, and for the Indian population, universal screening is recommended. So when do we do it? The Government of India and DIPSI recommends the first screening at the first booking visit. So even if it is 8 weeks, 10 weeks, 12 weeks, 14 weeks, we must do a sugar test to find out about the gestational diabetes. A mandatory testing has to be done between 24 to 28 weeks, and both GOI and DIPSI agree on it. While DIPSI also recommends a third testing if the first two are normal. between 32 and 34 weeks. So how do we test these women? Now, the flow chart which I have copied from the Government of India manual on gestational diabetes reads as follows. When we talk about pregnant women, the testing of GDM has to be done at the first antenatal visit by giving 75 grams of glucose. If it is positive, that is 2-hour blood sugar level is more than 140, we treat her as gestational diabetes. Now, if the booking visit shows that the sugar is less than 140, repeat testing is indicated at 24 to 28 weeks by the same method, and here we would certainly diagnose some more gestational diabetes. So how do we do this screening test? Now, DIPSI, that is Diabetes in Pregnancy Study Group of India, which has formulated this particular test with help of FOXY, is extremely easy and very, very important as far as our population is concerned, because this particular test is researched on Indian population. So how do you do it? It's a single step test using 75 grams of oral glucose and measuring blood sugars 2 hours after ingestion. So what we do is we give a 75 gram glucose, which comes in a packet, it is added in 300 ml of water. So it really doesn't matter whether the patient is fasting or in a non-fasting state. So this test can be done irrespective of last meal. The solution has to be completed within 5 to 10 minutes. A plasma standardized glucometer should be used to evaluate blood sugars 2 hours after oral glucose load. If vomiting occurs within 30 minutes of oral glucose, the test has to be repeated the next day or a little later. And the threshold blood glucose level of more than 140 is taken as cutoff. So how do we interpret it? After giving 75 grams of glucose, when the blood sugar levels are, or the plasma glucose level is less than 120, we say that the level is normal. If it is between 120 and 139, we say that it is gestational glucose intolerance. If it is between 140 and 199, we say that it is gestational diabetes. And if the sugars are more than 200, then probably we are dealing with a patient who is over diabetic. And these women have to be carefully monitored because these are the ones who are more likely to develop hypertension. They are more prone for retinopathies. So periodic fundus examination is a must. And their renal monitoring is also very, very important. WHO has described in 2016 its own way of diagnosing gestational diabetes, though it is very well accepted world over. I personally believe that the DIPSI is more appropriate for our country. Coming to the management, and the management has to be in accordance to the available national resources and infrastructure. What are the aims of management? Important aim is antenatal care with a GDM trained healthcare provider. So the person who's going to render antenatal care should be well aware about GDM and its issues. Frequent follow-ups may be required, and self-monitoring of blood glucose for all pregnant women with diabetes. So you've done a DIPSI test, and if it turns out to be more than 140, how are we going to manage this lady? What is recommended is medical nutrition therapy for 2 weeks and daily exercise of at least 30 minutes. So when we talk about medical nutrition therapy, it is prudent that we take professional help of our dietitian colleague who charts out a diet plan as per the need of the patient. And any kind of exercise is a must during the course of pregnancy. So after you recommend MNT and physical exercise, we call the patient after 2 weeks for a follow-up where we estimate her 2-hour postprandial blood sugar level. Now, if the postprandial blood sugar level is less than 120, we continue medical nutrition therapy and we ask the patient to continue physical exercise, and her 2-hour postprandial blood sugar has to be monitored as recommended by the physician, which is usually at least once a month. We may ask her to check it at least twice a month. But if the sugar done postprandially is more than 120 milligrams percent, we have to think of starting a therapy, and it could be oral anti-diabetic drugs or even insulin. Coming to the medical management of insulin versus oral hypoglycemics, these two are accepted therapies for medical management of a pregnant woman with GDM, which is not controlled with medical nutrition therapy. There was a time when insulin was the only choice we had, but now safety of metformin is definitely there as far as management of GDM is concerned. Insulin can be started anytime during pregnancy. It is recommended that metformin can be started at 20 weeks of pregnancy. We must keep a watch on hypoglycemia and weight gain. Metformin is less likely to produce these as compared to insulin. Coming to the oral hypoglycemic agents, these are the three oral hypoglycemic agents which are used. I have personally do not have any experience with acarbose. In most of the cases, the drug that we are using is metformin. It definitely helps in controlling blood sugars and predominantly the fasting sugars. It is safe as far as hypoglycemia is concerned. We do not see hypoglycemia like we see with insulin. There is a small chance that the patient may not tolerate the medications well. It definitely has a beneficial effect on the insulin resistance. It is weight neutral, and we can prescribe a sustained release formulation depending on the sugar levels. Of course, metformin has its own set of problems. It was noted that metformin exposed children had higher BMI and increased prevalence of overweight and obesity even at 4 years. And there could be certain side effects which are seen in the long-term phase as far as metformin is concerned. Coming to the insulin therapy, it's a complicated chart again taken from the Government of India Manual on Management of Gestational Diabetes. So you can certainly refer to it. And like as usual, we monitor the blood sugar levels, the postprandial and fasting sugar, where we adjust the dose of insulin as per the sugar levels. So between 120 and 160, we would offer 4 units. Between 160 and 200, 6 units. And if the sugars are more than 200, 8 units. Of course, fasting and postprandial blood sugar monitoring is more frequently required, which is done every 3rd day. How do we monitor these pregnancies? Monitoring pregnancy is extremely important because we are likely to face challenges even in all trimesters. So in the first trimester, apart from clinical examination, it is important that we subject her to a dating scan, nuchal translucency scan, and biochemical screening. We must also look at the uterine arteries for predicting preeclampsia, and we also must look for intrauterine fetal growth restriction. In the second trimester, we continue to examine the patient clinically. Anomaly scan is very, very important at 19 weeks. If you've not offered her a double marker, one may think of doing a quadruple marker if required. A fetal echocardiography is recommended at around 22 weeks. The care continues even in the 3rd trimester, where we would like to monitor the fundal height and abdominal girth, which will give us a clue about the fetal weight. Growth scans may be offered at 28, 32, and 36 weeks. Of course, with COVID times, we may have to differ with some of these scans. Color Doppler, as and when indicated, and non-stress test is to be offered after 32 weeks onwards, especially if she is on insulin. What is the role of steroids? Betamethasone administration for gestational diabetes mellitus is recommended only if there are signs of preterm labor, and after you give steroids, close maternal glycemic surveillance is a must, and we may have to think of admitting patient and monitoring the sugars for next 48 hours or so. The care has to continue during labor and delivery, and this is what is recommended by FIGO. Of course, this is for our own standards. So what we do is assess the patient thoroughly at 38 to 39 weeks. Estimated fetal weight, if it is more than 4 kgs, we may think of offering elective cesarean section, especially if there are other obstetric indications. If the weight is less than 3.8 kgs, depending on the control of sugars, patient's compliance, history of previous stillbirths, and vascular disease, we take a call whether we induce labor or we continue the surveillance and monitoring till about 40 to 41 weeks. When to deliver is the $1,000,000 question, because all colleges, all organizations have their different views. The RCOG says that discuss the timing and mode of birth with pregnant women with diabetes during antenatal appointments. Pregnant women with type 2 diabetes mellitus, induction of labor or cesarean section between 37 to 38 plus 6 weeks. If there are some other issues like metabolic or other maternal or fetal complications, elective birth before 37 weeks, and diabetes should not be considered a contraindication to attempting vaginal birth after a previous cesarean section. The SOGC says, and which many of us believe, that we must counsel the patient about the consequences of gestational diabetes and may be offered elective induction between 38 to 40 weeks of gestation, depending on the glycemic control and other comorbidity factors. WHO has a different view altogether. It says that if GDM is the only risk factors, induction of labor before 41 weeks is not recommended, and induction of labor is not recommended for suspected fetal macrosomia. How do we take care of this woman in labor and delivery? It is important that we monitor her sugars very well during the course of labor. So once she's admitted, we do a CTG, find out the heart rate pattern. A partographic monitoring is very, very important to assess the progress of labor. Blood sugar by glucometer is done every 2 hours, and we try and keep the sugars between 80 and 120. Continuous fetal monitoring should be done ideally electronically, if not at least physically. If a patient comes in a spontaneous labor and if she's on insulin or oral antidiabetics, CTG is an important thing. We must continue monitoring her on partograph. Sugar monitoring is extremely important, and IV fluids have to be administered as per the blood glucose level. But what is very most important is that this patient has to be managed in an institution where facilities for emergency cesarean section and care of the baby are there. It has to be done in presence of expert obstetrician, because vaginal birth is associated with a lot of challenges, and closed electronic monitoring is the key as far as management of labor and delivery is concerned. The second stage has to be managed carefully. We must anticipate shoulder dystocia. We must anticipate that this woman may land up in an assisted vaginal delivery. A neonatologist or a person trained in resuscitating the neonate should be present when the birth takes place. The third stage has to be managed actively in order to avoid postpartum hemorrhage, and we also must look for traumatic postpartum hemorrhage, because injuries to the genital tract are quite likely. So the important message as far as delivery is concerned: close monitoring in the second stage, watch for fetal distress, and vaginal delivery should be preferred, and LSA should be done for obstetric indications only. Please note that stillbirths are known in the second stage of labor, so we really have to be watchful as far as the fetal heart rate is concerned. But the care ideally has to begin in the preconception period. So this lady, when she decides to conceive again after a span of a couple of years, we must tell her that she has to take supplements of folic acid and even B12. Lifestyle modification is something which has to be explained to her right from day one. And universal preconception screening for malnutrition, anemia, overweight and obesity, hypertension, diabetes, and thyroid dysfunction has to be taken up. Our care continues in the postpartum period as well, and in the postpartum phase, the woman may need support for breastfeeding. We must also look for early signs of infection. We may think of giving her advice as far as the spacing is concerned. retesting of all women is extremely important, and it should be done between 6 to 12 weeks postpartum, and she has to be counseled about future blood glucose test. How do we screen her? We screen her again with the DIPSI test 6 weeks postpartum. If the sugars are normal, we have to counsel her that she has to manage her weight, she has to have good amount of physical activity, and she has to continue yearly assessment of glycemic status. But after 6 weeks of childbirth, if you notice that she has diabetes mellitus, she has to be referred to an endocrinologist. Coming to the contraceptive choices, barriers, long-acting reversible contraceptions, progesterone-only pills, DMPA can certainly be offered, but COCs, implants, and rings are contraindicated, especially in women who have gestational diabetes with macrovascular disease. So to conclude, universal testing of all pregnant women for gestational diabetes mellitus has to be done. Testing is recommended twice in pregnancy at the first antenatal visit, and then mandatory testing at 24 to 28 weeks of gestation. DIPSI recommends additional screening at around 34 weeks. A single step 75 gram 2 hour OGTT is performed, and that is something which should be offered to each and every pregnant woman. Women who are diagnosed to have gestational diabetes should be started on medical nutrition therapy and exercise for 2 weeks, and after checking a postprandial blood sugar 2 weeks down the line, we have to discuss about further management, whether she is to be offered metformin or insulin therapy. Each delivery with administration of prophylactic corticosteroid therapy for fetal lung maturity to be planned only if uncontrolled blood sugars or if there's any other obstetric indication. Vaginal delivery is preferred, and LSCS for only obstetric indications or fetal macrosomia. Neonatal monitoring is to be done for hypoglycemia and other complications. And we must not forget a postpartum evaluation of glycemic status by a 75 gram OGTT at 6 weeks of delivery. Thank you very much.
It was
unmute yourself, please.
It was really an excellent talk by Dr. Parag. He has nicely narrated the management of GDM as 1/3 of pregnant women they are suffering, and due to the complications and comorbidities, he has explained very nicely that are really troublesome not only to mother but to the fetus also, in terms of preeclampsia, hypertension, UTI, macrosomia, heteroamnios, spontaneous abortion, preterm birth, PPH, and increased CS rate, peripheral infection, and so many. It was very nice. Thank you, Dr. Parag.
Thank you.
I want to add one thing, sir, Dr. Biniwala. I just exchange my views. So we have managed everything with great interest and successfully. I think it should be rendered to the sub-centers so that the facility and the knowledge and awareness can be availed to the persons who are remaining in the far away in the village area. So if this DIPSI test is addressed or taught to the health providers at sub-center, they will take the benefit. The patient will also be benefited, just like this tetanus toxoid, just like this hemoglobin. This universal screening, the patient can reach to that far away women also, and so we can improve the fetal and maternal outcome also. This is my view.
Absolutely. So, I totally agree with you, Dr. Maya. It's a very, very simple test. The packet that is available in the market, which contains 75 grams of glucose, costs around 55 rupees. And facility of blood sugar testing is, if it is there at the sub-center level, all you have to do is to start doing yourself and teach whoever comes across in your contact.
So now, you see,
if you decide to push it, it is done.
So common.
It
will also become.
So this is also a very, very simple intervention, and I'm sure Dr. P.K. Shah will also agree, because this was researched for a very long time, and this is something which we as obstetrician have to push, because it's a simple test. We are doing blood sugars. I'm sure even in the smallest places, they should be having a glucometer somewhere in the subcenter or in the town. And it's not something which we are recommending out of the world. It's a simple blood sugar estimation,
Yes.
only to be done after administering 75 grams of glucose load, right? And if I'm attached to a municipal hospital where we've persistently pushed it, and it is now a mandatory thing, and it is being done, that all pregnant women who are attending antenatal OPD of this municipal hospital are subjected to DIPSI OGT between 24 to 28 weeks. And we've started detecting gestational diabetes, and we are of course managing them better. Obviously it would have a better impact on the perinatal outcome.
Thank you.
Can just take a couple of questions with your permission.
Yeah.
We'll start with Dr. Parag. I think sir has an appointment with a doctor and he needs to leave. There's just one question for you, sir. The question comes from Dr. Ishrat from Bhopal, and she's asking what are the different insulin preparations we can use and how to decide the dose of insulin.
Okay. Now, see, as far as insulin is concerned, the chart which is there now, whatever is the recommendation of Government of India, I think it's very, very simple to use. We somehow have been using metformin for a very long time. In fact, there was a time when none of us were ready to accept metformin as a therapy. I still remember about 12 years ago, we did have a group of doctors who had come down from New Zealand, and they had done a lot of work in the use of metformin. And now metformin is an accepted therapy as far as management of gestational diabetes is concerned, and we are using only metformin, and only if the sugars are not controlled with metformin, then we are administering insulin. And of course we do take into picture either a physician or an endocrinologist who guides us as to how the insulin has to be administered.
Thank you, sir. This question is for Dr. PK Shah. This is from Dr. Leela Sharma from Jamshedpur, and she's asking if the mother's indirect Coombs test is positive, do we need to give anti-D or not?
No, do not give.
Thank you, sir. Next question comes from Dr. Shuchi Jain. She's from Jabalpur, and she's asking, can we use single anti-D at 28 weeks if patient has already received anti-D in previous pregnancy?
Yes. No, if you give during antenatal period 28 weeks, irrespective of whether she has taken in previous pregnancies or not, immediately after delivery, you have to give again 300 micrograms to cover the fetal-maternal hemorrhage during labor, because that is maximum 50 to 55%. That also has to be covered.
Thank you, sir. There's one question from Dr. Mamta Parihar from Dhanbad, and she's asking, is there any effect on the child if both the parents have O positive blood group? I know it's a little different from your talk.
No.
Probably she's asking about the minor blood groups.
No, at least I don't know this. But same blood group, I don't think there should be much of a problem. If both mother and father both have the same blood group, whether it is O positive or O negative, it doesn't make much of a difference.
Thank you, sir. I think that concludes the questions. There are a lot of commendations and a lot of felicitations from across the audience that both of your lectures were very informative, very practical, and very detailed. So all of them are thanking you and congratulating you.
Pratik, there's a comment in the chat box, and I want you also to
yes, sir,
give your opinion. There's somebody. The name is not there. It's a number. So
okay.
The comment is that metformin cannot be used in the first trimester, but I'm sure there are a lot of people who put patients on metformin during even the ART therapies, ask the patients to continue it, and we really don't have enough. We really don't have too many conj anomalies or whatever. PK sir, what is your opinion?
Yeah, I can continue. If you already started metformin, you don't have to stop if she becomes pregnant.
Absolutely.
You can continue up to 20 weeks of gestation.
So PCOS patients we provide metformin
Yes.
Okay.
and
Okay.
they do
Pratik,
very
that was
well.
Dr.
And
Banita
it's
Sahai. She has
continued
not
up to
named her.
Yeah.
12 weeks.
Even PCOS, the same thing. Madam, don't do that.
So we'd like to conclude this session by thanking both of our esteemed speakers. I would request the chairpersons for this session to please give their concluding remarks so that we can close this session and move on to the panel discussion. Dr. Pardeshi, sir.
So this was really a nice session by Dr. PK Shah and Dr. Parag Biniwale, because Dr. PK Shah has narrated really very nicely in RS negative pregnancies, and Dr. Parag in the management of GDM. It was very nice, very informative and practical basically. Thank you so much.
Me
Thank you,
also,
sir.
I have already given my opinion regarding the reaching of this all recent management of diabetes to the far, far distant village people, and about the early detection, early screening, early good management will certainly improve the outcome in both the conditions. The incompatibility, the GDM complications, all the complications are going down, and one day will come when we will conquer the GDM, but the condition is increasing. The incidence of GDM is increasing day by day. So by increasing our ability and reaching the quality to the far distant population, we will conquer, we will reduce, we will come to the no maternal complication, no fetal loss. So this is our wish. And if I go on continuing this type of webinars, CME, repeating all these problems, we will certainly improve and reach each and every doctor will know this, and each and every person will be benefited. This is my view, opinion, and wish also.
Thank you, ma'am.
Thank you,
Dr.
Maya
Banita
ma'am,
Sahai,
for
ma'am.
giving.
Is Dr. Banita
Yes.
Sahai with us? Ma'am, we can't see you, but I
Yes,
think your
I
messages
have
are
been
coming through.
I have been this video of mine is just it has not been started from the host co-host.
Okay, okay.
I have asked to
Yeah, we
start,
can see
but
you
I
now.
cannot.
Yes, we can see you.
Okay. Okay, so it's a wonderful thing. It's you people are giving us a basic knowledge in a very simple way and very elaborate way. And this we require if but sometimes comes in our mind what to do, what not to do. And the Dr. PK Sah sir, he has told about the when to give this RH anti-D at before abortion, after abortion, at before 12 weeks. Those things are very important, very remarkable, and these are the basic things when we get confused at the time of our treatment. So it's a wonderful lecture and very simplified by Dr. Parag Biniwal also, sir. It's a very simplified GDM, and so it gives lots of knowledge and encouragement to we want these type of the basic things should be repeated in the futures also, Dr. Pratik sir. You have
Thank you,
done a
ma'am.
wonderful job.
Thank you so much. Is Dr. Kavita Priya with us? I saw her briefly earlier. If she is with us, we would request her to please speak. No, I don't see her. Dr. Geeta, madam, should we conclude this session and move to the panel then?
Yeah, please, sir. Please, we can move to the panel discussion. But before that, I want to say something
Yes,
about
ma'am.
you, sir. You have done so much for this webinar, and really we are thankful to you to given us such knowledge and such organized this webinar very well. So, Dr. Pratik, I feel privileged to introduce you, Dr. Pratik Tambe. He is MD FICOG. Just a minute. Hello, am I audible? Am
Yes,
I
ma'am, we can
audible?
hear you.
Yeah, okay. Dr. Pratik Tambe, MD FICOG, AIT consultant and gynec endoscopic surgeon. International Diploma in Advanced Laparoscopic Surgery from Clermont-Ferrand, France. Trained in Assisted Reproduction in Brussels, Belgium. Chairperson AMOGS Endocrinology Committee 2020-22. Governing Council Member ICOG 2021-22. Executive Committee Member ISTAR 2020-21. Managing Council Member and Patron Mumbai Ops and Gynae Society MOGS. Chairperson Foxy Endocrinology Committee 2017-19, Managing Council Member IAGE MSR AMC 2015-18, recipient of 15 MOGS and 7 Foxy Prize and Awards. Foxy Dr. Mehru
That should be enough. That's enough, ma'am.
and
Introduce
the
the
Best
panelists.
Committee Award. Editor of 10 books. My God. Sir, how could you get so much time? My God. Really, it is amazing. Your introduction,
Dr.
it can't
Pratik,
be
you have
complete.
not left any award for others.
Nothing left, sir. Really, it is amazing. And we are inspiring
Thank you so
all.
much. Thank you.
Thank you, sir. Thank
Thank
you,
you
sir.
for the kind
And
introduction.
we have a panel discussion. Sir is the moderator. Please, sir, start.
Thank you so much. I'd like to introduce our panelists who have been waiting very patiently right since the beginning of the program. To start with, we have Dr. Ruchita Sinha. She is the secretary of the Jamshedpur OBGYN Society. She's an assistant professor at Manipal Tata Medical College and she is a specialist at the Tata Main Hospital. She is a very renowned figure in academia and we welcome Dr. Ruchita Sinha. Thank you so much, ma'am. Next slide, please. Dr. Anupriya Prankaj is the secretary of Bokaro Obsgyne Society. She is a consultant at Hope Hospital, organizing secretary for the Jharkhand IMA and DOGS conferences. She has several publications and presentations. She is a Manyata trainer and assessor for Jharkhand and she is the mission secretary for Pink Health. Welcome, Dr. Anupriya. Next slide, please. Dr. Neetu Sai is the director of New Shri Clinic in Dhanbad. She's been bestowed with the Nari Samman Award in 2019, Best Doctor Award by Dainik Jagran in 2018. She is trained in gynec laparoscopic surgery. She's the secretary of the IMA Female Wing at Dhanbad and she's organized several conferences, been faculty at several AICOGs as well. Next slide, please. Dr. Alka Agarwal is the immediate past president of the Jabalpur OBGYN Society. We had met when I visited Jabalpur last year. Dr. PK Shah sir, you will remember that occasion when we spoke. We did a Hello Tomorrow CME there and there were 3 panels and Dr. PK Shah was one of the moderators there. It was a very pleasant trip and thanks to Dr. Alka Agarwal for organizing such a wonderful program at that time. She has been the recipient of a national award for Pradhan Mantri Surakshit Matrutva Abhiyan, PMSME, and she's also been felicitated by the MP government for providing continued excellent services to antenatal patients. During Dr. Nandita Palshitkar's tenure, she has won the Wonder Foxian Award and also recipient of the Wow Foxy Brahma Kumaris Award. Welcome, Dr. Alka Agarwal. Next slide, please. Dr. Meera Lakhtakia has unfortunately excused herself from today's panel owing to social issues. Next slide, please. Dr. Juhi Agarwal is the secretary of the Bhopal Society in 2017 and 18. She's a professor at GMC in Bhopal, has several papers in national and international journals, also presented at AICOG and various conferences. We welcome Dr. Juhi Agarwal. Thank you, ma'am, for being with us. Dr. Uma Pandey is currently the president of the Varanasi OBGYN Society and she's a professor at the prestigious Banaras Hindu University in Varanasi. She will be joining us shortly. She had assured me that once she finishes her work, she'll be joining by around 3:30. So we'll have her as and when she joins. Next slide, please. We have with us Dr. Elizabeth Jacob, who's the head of Department of OBGYN at Little Flower Hospital and Research Center at Angamali. For those of you who don't know where that is, I googled it and it's at the northern tip of Cochin city and it was educational for me as well because I had her as a panelist in one of my previous panels when we did a program with the Cochin Society. She is very well read, recipient of the Kalyani Devi Memorial Award for Best Paper at the COGS in 2014. She is the past president of Angamali Society, and of course, she is a very well-known and reputed teacher in her region. Thank you so much for joining us, ma'am. And if I may be permitted to share my screen, we will start with the panel, which is already quite late. Today's panel is on reducing cesarean section rates, and it's something which is very topical. And I usually like to talk about these things because often many of us are not addressing these issues. Whenever there is a lot of hue and cry in newspapers and media, that's when all of us go into defensive mode, and we don't realize that these are issues that we need to be thinking about and talking about on a routine basis, day in and day out, and not only when there is a hue and cry in media. Can you see the slides, please?
Yes.
Okay, all the panelists request to please unmute yourself. I like to start with a quotation, and the simple quotation that I have here is from E.M. Forster, who said once upon a time that the main facts in human life are only five: birth, food, sleep, love, and death. Today we are here to talk about birth and the complications that ensue when you perform what is an unnatural birth or a cesarean section. If you remember the headlines from newspapers a couple of years back, there were several prominent activists, one of which you can see here on the screen, who said that cesarean sections are being done for illegal reasons. It's a racket just to make more money out of patients. And often these are being done without any indication or proper documentation. Let's examine this, whether this is true, whether there are certain few black sheep in our family countrywide who are responsible for giving all of us normal ethical practitioners a bad name. So to start with, I want to examine whether we actually classify cesarean section indications. And to start off, I would like to request Dr. Ruchita Sinha to please comment. In your practice, do you classify cesarean sections? How do you classify them? What are the indications that you would normally put down?
There are various methods of classification.
Yes.
Some people classify according to indications. Then
Yes.
other classify like Robson 10-point classification. It is in fact a very good classification which classify according to maternal characteristics. And by that we can compare the different society we are catering comparison between different hospitals, and we can easily find the main cause of increased cesarean section rate, and we work on that group of people in order to decrease it. And definitely we have a HMS system built in which we always feed the indication. We use the indication price classification. We always feed the indication, and like that we classify.
Okay. I'd like someone else to comment. Dr. Alka Agarwal, madam, in your 2-3 decades of experience, how has our practice of documentation, indications, classification changed? Do you find that it is much different from what we were taught when we were medical college students?
Yes, at that time there were three categories, like immediate urgent LSCS, then fetal distress is there or APS there, then we have to do it immediately within 30 minutes. And then there was other indication like prolonged second stage of labor or maternal distress. In that case we can do it within 45 minutes. And then there was elective LSCS. Like elective LSCS was not much prevalent at that time. And this 10 group classification is very nice, and options classification, and it has guided us how to proceed in cases.
Thank you, ma'am.
It is related to...
In the good old days, we had only two simple indications, elective and emergency. Sometimes there was a semi-emergency cesarean section. Life was very simple at that time. We didn't have all that much difficulty in documentation. It was very easy to pass down to our juniors as well. Today, things have become a little more difficult, slightly more complicated. As you mentioned rightly, there is a 10-group classification now. And to further elaborate on that, can I invite Dr. Neetu Saha? Is she there with us? I don't see her. So then maybe Dr. Juhi Agarwal, ma'am, can you tell us a little bit about this Robson's classification? What is this Robson? Who is this gentleman? And why has he come and troubled all of us and changed all our practices almost overnight?
Robson's classification is a 10-group classification in which they have categorized broadly all these women who undergo cesarean section, because there are various indications. I mean, there are hundreds of indication of cesarean section, but in order to make a broader category, they have categorized this group into 10 group classification so that a proper audit can be done depending upon whether the woman is nulliparous, whether she was in spontaneous labor or the labor was induced, whether she is a case of cesarean section, whether this patient is female is a multiparous patient, or she is having a malpresentation along with that, or she is a breech presentation. I mean, there are 10 such classifications, and which has been standardized by WHO and I think by POGSI as well, so that audit can be done on a larger scale. And as you said, Dr. Prateek, that in media also it has been covered that we are doing unnecessary. This Robson classification will broadly categorize and help us to see where we are going wrong. And also, of course, it will help us find the rotten apples in the society too. So
I think what you have clearly underlined is that there is a need for us to be accountable, to document things well, and to ensure that there is an objectivity in our classification. It's not something which is subjective depending on us. I may think this is fetal distress and this is an emergency cesarean section. Dr. Elizabeth may disagree. She may feel that this is not an emergency. And those kind of discrepancies are what cause controversies. And when they get blown up, that is when the whole media starts bombarding us. So if we have something like a standardized universal classification, which is accepted all over the world, which has been thoroughly researched, and we start classifying according to this and look at our practices, probably we'll be able to identify whether our cesareans are, number one, justified, number two, the rates are increasing or decreasing, and number three, who are the people who may be taking advantage of these loopholes and giving the rest of us a bad. I think that's the purpose. Dr. Anupriya, I would like to ask you, are you using this Robson's classification in your practice?
Yes, sir. Actually, we are using this classification in our practice, and we classify and the patient why we are doing the cesarean section, and at the end of the month, we self-audit that which cesarean section was done for which reason and which could have been avoided.
Thank you, ma'am. So since you've raised the topic of audit, I think the next slide is about audit. So I would request you to just tell us in a couple of minutes, what is this concept of audit? To be very honest, when I passed out 25-30 years back, this term was unknown to me. What is research and what is audit? We were never taught. This is something which we had to learn after we had already passed out from medical school. After 10 years of medical college, I am ashamed to say that this concept did not exist in the 90s. It has come now and we have to learn this. Can you tell us what is this audit?
So audit is a retrospective thing. When we look upon some data, we do the audit and we self-assess why it was done, why what was the complication, which events could have been avoided, and all that.
Okay, Dr. Ruchita Sinha, anything further you would like to add to whatever has already been said?
So the best is a weekly peer review audit in which usually we should divide them into three categories, in which it was absolutely indicated, in which it was indicated but controversies are there, and which are like they can be avoided. And the patients falling into that group should be intensely interrogated why the cesarean was done, and in that way only we can only reduce the rate of cesarean section. Only by audit, this is the only method to reduce the cesarean section.
Okay, I think both of our panelists have told us in some great detail what audit is. I'll try and simplify it. Let us say, for example, we are trying to assess how many cesareans are done in a duration, say 1 month, 2 months or 3 months, for, in inverted commas, fetal distress. Okay, so we look at what are the current practices. How many cesareans are we doing in our institution for that particular indication? We measure that current practice. Then we introduce some changes. For example, you may say that all cesareans indications have to be weighted by bosses or seniors. They have to co-sign, or they have to say that yes, you can now go ahead. So we are bringing about a change. Once we change that, then after a period of another 2-3 months, we re-examine whether those figures are still staying similar or they have decreased or they have increased. Of course, there are going to be some seasonal variations, but by and large, this is how the audit cycle works in practice. Can I ask Dr. Juri Agarwal, madam, do you find that this audit cycle helps us as clinicians also to improve our practices, or is it only because for ISO or for Manyata or for a particular accreditation you need to show it on paper?
No, sir, definitely these audit cycles are like any other audit cycle as a child presents himself or herself in a test paper. And he continuously assesses himself that, yes, I have to work on this topic or I am weak in this. So similarly, in this audit also, of course, we will, suppose we have induced a patient, what wrong went in induction, probably our bishop score assessment was wrong, or whether we would have done a better thing for her, or whether we have induced this patient very early. Definitely, it will make us accountable and we will improve ourselves.
So I think you've underlined the very important concept that finally we need to be accountable not only to our patients but also to the institution and to ourselves. At the end of the day, we are providing a service. We are now looked upon as service providers. We are no longer treated as, in inverted commas, gods, which we once were. And I like this quotation very much, and I usually try to use it at least once a month wherever I speak. Accountability is the glue that binds commitment to results. If you're not committed, you will not get your end result. And if you're not accountable, you will be untrue to yourself. I'm going to bring Dr. Elizabeth Jacob now into the discussion and going to ask her, what has FOXI and ICOG done on this front? Have we done something specific to address all these media highlights that maybe we are going wrong somewhere?
The FOXI has brought in the good practice guidelines as far as the cesarean sections are concerned, and they have done projects in order to promote this 10 group classification and accountability and minimum standards of care when we are performing a cesarean section, the procedure for the cesarean section, the pre-op checklist and the post-op checklist for the same. So based on that, the clarity of doing a cesarean section for a particular indication has been conveyed both to the institution where you're working and also to the public in general. So the FOXI has given us clear-cut guidelines as to how we need to proceed whenever we are planning for a cesarean section.
Thank you so much. I think all of us are aware about the Manyata project, and in Karnataka we also have the Lakshya Manyata project along with Maharashtra as well, launched in unison with the government of Maharashtra. There are certain standards which are there for safe delivery. Dr. Rishikesh Pai is the administrator for the project. My very good friend, Dr. Amay Purandare, is one of the people who propagates this all over the country. And usually when we had physical conferences once upon a time in a different era, there used to be a dedicated Manyata session in most of the conferences where these ideas were propagated. So this is the first time anywhere in the world that public and private partnership has happened on this particular front. Certain standards have been published and we are undergoing a process of accreditation. So if your institution is not Manyata accredited, highly recommend you to please approach the NPMU at FOXI. They will be very happy to guide you. They will train all of your staff also what are the standards which they need to follow, and then you will be accredited in this. I don't have further slides on Manyata just now to show, but please get in touch either with me, with Amay or with FOXI office, and they will be very happy to guide you. This is just a brief primer to introduce all of you to the concept that we are going to discuss, and hopefully all of you are warmed up. Let's go to the actual cases since we are already 15 minutes into the panel. So this is a 30-year-old primigravida. She's had an uneventful course, good class of patient, regular with visits. At 39 weeks, she has an engaged cephalic presentation, 3 kilograms baby. And like most primigravida who are from the modern era, who are very Google friendly, they read up a lot of things on the internet, or they have received advice from their friends, and they are extremely scared of labor pain and vaginal delivery, both. So she comes to you saying, Doctor, I want to have an elective cesarean section. She's already reached 39 weeks now. She has not gone into labor so far. I'm going to ask Dr. Alka Agarwal, madam, in your practice, is this common? In cities, we definitely have what is called, in inverted commas, maternal request for cesarean section. Are you finding that even in Jabalpur, you have a similar patient group which is coming to you?
Not so much as metro city, but now patients are coming. They are very much afraid of PV and PV examination and vaginal delivery. So they are so much afraid they don't allow us to do the PV also during first antenatal checkup and then later on also. So I think proper counseling is very much necessary. Or if we give them antenatal classes, so since start, if they have a rapport with their obstetrician, then they will obey the things which will tell them. We should take in antenatal classes. We have breathing exercises, pranayam, yoga, other perineal exercises, and when they see their other fellow pregnant ladies are delivering normally and they are not afraid, so their fear will also go off. And when they see that their these antenatal friends, they have delivered normally, it will encourage them to have a normal delivery. Then we can say that if you are so much afraid of pain, we can offer you obstetric analgesia, and you are 39 weeks, your pelvis, I have to assess the pelvis and cervix. So both are things, because she is having engaged head and 30 years and weight is also proper. And if her pelvis is roomy and cervix is more than 6, Bishop score is more than 6, then I will tell her that you should go for vaginal delivery. That is a good thing. It will help you in the future.
So I think there are several important points that you brought out in the short time that you spoke. I'll just repeat those for the sake of the audience in case they've missed them. Number one, you have identified that this is a low risk patient. Number two, you want to ensure that the cervix and the pelvis both are favorable for a normal delivery. Number three, the importance of getting the patient ready in the second and third trimester itself, making her mentally and physically prepared by doing counseling, by ensuring that she attends some antenatal classes. There is some physical exercise which is being performed. She is not on complete bed rest, being treated like a princess by the mother and the in-laws or the entire family at home. That sort of behavior is quite common. But then that's something which will preclude a vaginal delivery. So we must encourage some amount of classes, some amount of exercises. And to come to the issue of assessing the cervix, Dr. Ruchita Sinha ma'am, do we still perform internal examinations for, say, assessing what the cervix type is at term, at 38, 39 weeks? It's something which we used to commonly do once upon a time. Is it still done?
Yes, sir, of course we do a PV examination. And in a few high-risk cases like eclampsia or a patient which is in critical care, that is very important to time, like how much time we have from induction to delivery. Particularly important for assessing how the induction will be successful or not. And we use it for like second dose of Savi-Prime should we give, or use other method of induction.
Okay, so I think we have now come to the state where we have managed to convince the patient that she should try for a vaginal birth. She is now mentally ready. Now the mother-in-law wants delivery on an auspicious date. And though we cannot as OBGYNs ensure that she delivers on a particular day or a particular date and time, which is not probably easy for us for a vaginal birth, some amount of assessment is required before we plan for a vaginal delivery. I see Dr. Uma Pandey has joined us and she is drinking her trademark green tea. Madam, can you tell us a little bit about what is this Bishop score and is it still relevant in modern obstetrics? We can't hear you. You need to unmute yourself.
I said you got me at the right point. Yes, we do use Bishop score, and it is still relevant, especially when you want to assess the woman and repeat it repeat examination and make your decision from there. So yes, it is relevant, and it has been, earlier it was Bishop. Now we have modified it a little bit and we use that. So in our medical college, we use it. The advantage of it is that even a midwife could write examine if she has been trained. Then she can write it on the partogram, and then we can make an assessment rather than every person who wants to see the woman examining again and again.
So I think you've underlined the importance of the Bishop score. What are the non-pharmacological methods which you know which will help to hasten the onset of labor? Castor oil is very popular in Bombay. What about your practice? Do you see that as well, Dr. Uma?
We do not, Dr. Pratik, we do not use that castor oil thing.
No, we don't use it, but it's very common for the relatives to give her castor oil. It's something which we encounter in practice. I don't think in the 21st century, Dr. Pratik Tambe should be inducing labor in patients with castor oil. Thank you very much.
Okay, no, the only that non-pharmacological thing which I know of is membrane sweeping. And membrane sweeping, very clearly we would counsel the woman when we are doing that in the outpatients. Like you would explain to the patient, listen darling, this is the thing which we are going to do. We are going to examine internal examination. It might be a little painful for you. There's also a slight possibility that there will be pinkish tinge coming out from the vagina, maybe today, maybe this evening. You should not worry about that. But if it is more than that, if there is bleeding, then you must come to the labor room. Then, because it works only in 10% of women, so you should also inform the woman that this is not a wonder thing we are doing. It could be uncomfortable. We will do only if you want us to do. Otherwise, you have every right to decline this. That's the way we used to do counseling of women in England.
So this is a standardized chart and a patient safety checklist which is recommended by the RCOG as well as the American College. And though we always say Bishop score, induction, pelvic adequacy, often it happens that none of us actually document it, or we don't use standardized charts or documents for ensuring that this assessment is there on paper. Tomorrow in the event, unfortunate, if something does go wrong, you could be pulled up for not having it down on paper. And that's where these kind of simple checklists, which are there easily available on the internet, you can download them, print them, incorporate them into your indoor charts as well, or your indoor papers, and these can help you in difficult times. So we've been talking for the past 20 minutes about induction of labor when we were actually supposed to discuss reducing cesarean sections. So I think one of the ways in which we can reduce cesarean sections is to try and reduce the unnecessary, unindicated, in inverted commas, cesareans like this young lady where there was a maternal request, and probably with a favorable pelvis, you would have a normal vaginal delivery and a cesarean may not be required. So I think we've underlined some very important things, that good counseling is important. You need to offer safe vaginal delivery by counseling, antenatal classes, physical exercises, maybe some amount of labor analgesia. I don't know how approachable patients are and how frequently you have anesthetists available. Dr. Anupriya, do you think labor analgesia plays a very big part in your practice? Is Dr. Anupriya there? I don't see her. Dr. Ruchita Sinha, ma'am, would you like to take that?
Yes, so we are using epidural analgesia, and after we usually 4 centimeter dilatation, we use it, and it is very comfortable for the patient, and usually we have seen good results with this. So best is epidural analgesia, otherwise opioids or pethidine.
But how often do patients actually request for labor analgesia? What is the incidence of patients knowing that such a service is available to them? Is it quite frequent or is it rare?
This is another research question, Dr.
Frequent because of hospital being an industrial hospital and caters patient to certain good socioeconomic status. So usually they demand for epidural analgesia.
Yes, Dr. Julia Agarwal, you were saying something.
Yeah, sir. I'm telling ki that is again a research question, that how many women do they know whether
Exactly.
analgesia actually exists? Because I
Yes.
work in a tertiary care center, and all women they know. Mother-in-law counsel, दर्द तो होएगा, दर्द के बिना बच्चा होता है क्या?
So I
Sir,
think
I think
again we are partly to blame because we are not propagating this
Actually,
concept that labor analgesia is now
yes.
freely and widely available. Of course, from different place to place, what is the availability of anesthetists for administering it and monitoring it may vary, and then finally delivery of that particular service may vary from practice to practice. Dr. Elizabeth Jacob, you're from Kerala,
Yes,
which
sir.
is which is the state which has the lowest maternal morbidity and mortality figures. I
Yes.
think your practice must utilize a lot of these so-called modern concepts. Am I right?
Yes, sir. So I just wanted to add up for this that in our practice, antenatal classes has become universal. Even in the smallest setup, we are having regular antenatal classes except for the COVID situation that's now prevailing. So in the antenatal classes, the patients are already given a complete description and a complete knowledge about the easy availability of epidural. And what we have found in our practice is that using epidural, the success rate of delivery, induction and delivery is more. Definitely more because the patient does not have pain. So she tolerates better, and because there is no pain, the progress of the cervix is also better, and not much of issues regarding instrumentation in the second stage. So we would strongly recommend our women to take epidural, and almost more than 50% of our women are willing to take epidural. So
That's very heartening to note. I think Dr. Uma Pandey has a point to make.
Just one point, Madam Dr. Elizabeth,
yes, ma'am.
is that I know I respect the states and policy and maternal mortality, and I come from one of those states where it is very, very high. But if you give women epidural, she might just sleep through the labor, and it's wonder thing for her, and then she would deliver. Suddenly, the midwife or us would examine, and she's fully dilated, and then you are geared up for delivery.
Yes,
but there are enough researches to show that if you give epidural anesthesia to a woman, the chances of operative vaginal delivery in terms of forceps delivery has increased. Except when the mobile epidural has come, which we use as well sometimes in BHU, rarely I must admit. In that scenario, the instrumental delivery rate might be low, but the center where I worked, our epidural rate in that center was 80 to 90%. But so the forceps delivery rate was also high because women were able to push.
Ma'am, the outlet forceps in vacuum deliveries may be a little bit higher, but that will definitely not contribute to a higher rate of complications for the woman or to her baby.
No, I'm not talking about complication. No, please get me right. It is not the complication. It is the incident. It is proven beyond doubt that it increases. There are enough researches available.
So let's get back on track. I think there is some controversy whether number of instrumental deliveries increase after
I
labor
want to
analgesia.
interrupt a bit.
Yes,
sir, I want to add one thing, sir. Just a little thing. That we have been talking about epidural analgesia, but can we practice in a busy labor room where 50 or 40 deliveries are occurring in a day?
Yes.
Can we practice
that would be a problem.
and tramadol and pethidine type of
yes.
drugs? So that, because when I was a student, Dr. Daftari took a lecture, and since then I have been practicing those things. And I think that
I'll
is
be
also
sure to convey that you are implementing programmed labor even today in 2020 to Dr. Daftari, because I love listening to him talking on that topic. Maybe one of these days we'll invite him.
But definitely some form of analgesia has to be offered to women in labor, because unless that is offered, our cesarean section rates are going to be high.
Agreed.
So this is the Foxy Good Clinical Practice Recommendations on Induction of Labor. These were released in 2018 when Dr. Shanta Kumari was the chairperson of ICOG and Dr. Jaideep Malhotra was the president. There are a lot of good recommendations there on how to make induction of labor and vaginal delivery more feasible and easy for our patients. If you have difficulty in finding it, it's there on the Foxy website. If you can't find it, please write to me. I'll send you a copy. Foxy also has a position statement on cesarean section rates, and in a different era when we used to have physical conferences, this is our Secretary General, Dr. Jaideep Tang, speaking at the West Zone Yuva Foxy in Udaipur. I think this was, yes. And this entire conference was themed on the art and craft of vaginal delivery. This is his statement. And again, Dr. Jaideep Tang's statement and the Foxy position statement is there on the website. Please download it, read it. If you don't have access to it, feel free to write to any of the Foxy office bearers. They will share it with you. Foxy also did an audit of clinical techniques called as the FACT Conclave. This was held in November 2019, one day before the Foxy Presidential Conference, C2D2. And the results of that have also been disseminated to everybody at AICOG in Lucknow. This was part of the kit bag. Again, if you can't find it, please feel free to write to me. Let's go quickly to the next case. This is a 30-year-old primigravida. She is admitted at 11 o'clock in the night. She has a spontaneous rupture of membranes at 38 weeks. She doesn't have any pain. She has normal findings on examination. Baby weight is approximately 2.8 kilos. The cervix doesn't look very favorable for immediate delivery. And you did an NST or an admission test, which is reassuring. It's 11 o'clock in the night. The resident has informed you that these are the findings. Dr. Anupriya, I think you've joined us again. Are you there with us? Yes, ma'am, you're there with us. So should we wait for this patient to go into spontaneous labor? Number two, should we immediately deliver her? Number three, should we induce her for vaginal delivery? What are the options that we have and which would you favor? We can't hear you, ma'am. You'll need to unmute yourself. Madam, please unmute yourself.
Sir, first we will take the history when the rupture has taken place. If the rupture has taken place within few hours, NST is normal and all other findings are normal, we can wait for spontaneous delivery. And as it is 11 p.m. at night, it is not advisable for induction of labor because we may land into some problem and anesthetist and neonatologist might not be available in the night. So I would go for wait and watch policy for spontaneous labor.
So how long do we wait? Do we wait till the consultant comes at 9 o'clock next morning for the morning rounds? Is that a safe period to wait?
Sir, I think I would wait for 6 to 8 hours.
Okay, so if she's come at 11, 6 to 8 hours would mean approximately 6, 7 o'clock in the morning?
Yes,
that's a
yes,
safe
6,
time?
7 o'clock. Yeah.
Okay. Anybody on the panel who has a differing point of view and feels that we should not wait for so long? Dr. Alka Agarwal.
No. We'll wait. We'll wait till morning. Yes, we'll wait till morning, or we can wait for 24 hours. But we have to give antibiotic, and because she's in good shape, we can wait.
Okay.
Pardon?
You had raised your hand.
Me? Is it me? Because I thought you were going to say that anybody who would not like to wait. So that's why I raised my hand. That I would like. I mean, there are scenarios. There is enough evidences to suggest that if woman has had rupture membrane and she does not have any complication in terms of chorionitis, meconium stain like or malpresentation, cord prolapse, all those things have been ruled out, then we can very comfortably wait for 24 hours. We do that. But also if you are in other societies, in other countries, you could perhaps wait till 48 hours because the circumstances, the examination, the instruments, the gloves, everything is clean enough, so we are not introducing further infection, and that increases the chances of women having spontaneous vaginal delivery, and that is why you are waiting. If you induce immediately with oxytocin, cervix may not be ripe enough. It might have just ruptured the membrane, but the ripe enough may not be there, and that's why it is advisable to wait. But it depends on your circumstances and the patient party and the counseling. All that.
Thank you. Point well taken. Dr. Anupriya wants to wait for 6 to 8 hours. Dr. Alko Agarwal is willing to wait for 24 hours. Dr. Uma Pandey feels she can wait up to 48 hours. Dr. Elizabeth has a different point of view.
Yes, definitely we can wait. About 75 to 80% of women will get into spontaneous labor. By waiting for spontaneous labor, the advantages will be two. One is that the latent phase will be reduced. So the active phase, you will get her into the active phase quickly. There will be better chance of her delivering vaginally. The second would be definitely a reduction in TTT and a bit of RDS, which might occur if you unnecessarily induce her early. So definitely we can wait. We can wait up to 12 to 18 hours. And since it happened at midnight, 11 p.m., we want the best utilization of the limited resources. So definitely not to induce her immediately at night, wherein we'll have limited resources. And if by chance we end up in any complication, we would be having a very bad day.
So I think the panel has universally agreed that if there is an emergency indication for immediate delivery, then we deliver. Otherwise, it would be safe to wait till next day morning or whatever. Now
So in the morning we will reassess.
Exactly.
After 6 to 8 hours we will reassess the patient that we have to wait now or an induction of labor is to be offered.
Absolutely. So the key problem here is that none of the guidelines mention how long you should wait and what is the choice of agent which you should use. So all of you are right, nobody is wrong, and as per the particular circumstances which are prevailing at that point, you will take your decision, as rightly pointed out by Dr. Anupriya. So now this is a patient who has labor rupture of membranes. You've waited for about 6 to 8 hours. The consultant has come next day morning and you are the consultant, Dr. Ruchita. How would you like to induce this patient? Her membranes are already absent. She is free flowing and there is a fear that she may go into dry labor if the spontaneous onset of labor does not happen. So you're going to induce her. What would be your agent of choice?
Sir, actually we are using oral misoprostol and it has good results. We can also use dinoprostone as well, but what we are using is oral misoprostol 4-hourly, 50 microgram, and it has very good results.
50 micrograms.
So we need continuous monitoring. Yeah, for 4-hourly.
Is so that a little too much?
So it has good results.
I agree, it has good results.
So we need
to request somebody else to comment regarding the dose of misoprostol. I'm not against misoprostol per se, but does anybody else on the panel have experience with misoprostol, specifically the dosage?
So we use 25 microgram of misoprostol. We do not use 50 microgram of misoprostol. 25 microgram, a maximum of 3 doses. But for this patient, a single dose of misoprostol would make it this thing. So early in the morning, like ma'am said, about 6 to 8 hours later, the resident can reassess and let us know. And in the early morning, we can give her a dose of misoprostol, 25 microgram.
So the fear is that if you give too much, especially with absent membranes, there is a very real risk that the patient will end up in hyperactivity and hypersystole, which would lead to meconium and fetal distress with compromise. And a patient who would otherwise have delivered vaginally normally would land up in a cesarean section. I agree with misoprostol, and usually for this reason, sometimes the old timers prefer a vaginal prostaglandin gel which is applied to the cervix. Dr. Alka Agarwal is smiling. Please, madam, tell us about this.
Yes, actually, she is having rupture of membrane. She is having leaking. Generally, this vaginal progesterone is avoided in leaking. So, oral, I think oral progesterone, this misoprostol is better.
Okay, actually, there is no difference whether you induce vaginally or you give orally. Yes, please.
Sir, can we use misoprostol in a full-term live baby, sir?
We can use misoprostol, but the dosage has to be regulated and the patient needs close monitoring, because oral tablet is like an arrow from a bow. Once it is gone, you can never recall it. It's not like oxytocin where you can switch off the pint and then within 10 to 15 minutes, the contractions will stop. It doesn't work that way. So therefore, close monitoring, supervision, and appropriate guidance is necessary. You can't just give her the tablet and go to sleep. Patient has to be monitored because the incidence of complications, including rupture, are much higher.
Can I put in a controversial method?
Yes.
So what would be the opinion in general about the use of Foley's in a totally unfavorable less than 4 bishop score with a PROM?
So Foley's is there a little later on in the panel discussion, but since you brought it up, I think many of us like to use Foley's induction, especially for very poor cervices.
Yes.
Key here is that the membranes have to be present. Since we are currently discussing membranes absent, we would be introducing infection with the Foley's balloon, and therefore
that's the point I wanted to raise.
we would avoid using it.
Yes.
So there are certain indications where we would not like to wait, and some of these were mentioned by Dr. Uma Pandey. I'm going to bring her back into the discussion and ask her, what are the leading questions that you will ask your resident on the phone to exclude so that you can sleep peacefully at night?
Okay, yeah, that is question to me.
Yes.
Well, I would ask the resident to examine the woman right from the top. Just to start with, that's a normal way of examining. If the woman is pale, very pale, severely pale, then you examine. Obviously, you take the pulse, you take the blood pressure. I hope that's normal. And you chest nowadays we have to do because of COVID infections. Then abdominal examination. Is the abdominal examination tender? If it is tender, whole abdomen is tender, or only the uterine contour is tender, and is she feeling any? Is the mother feeling any abnormal movements? Or else I would ask my student to do the speculum examination, and on the speculum find out if there is bleeding. If there is bleeding, not to do internal examination unless there is ultrasound which shows that the placenta is in the upper segment. All these things have to be excluded. Also, it is said that rupture of membrane has to be confirmed, and it is said that check that the cord is not there, check that the hand is not there, and any portion of the baby is not there. Minimum, as far as I remember, these things must be checked before we can let the woman lie down and comfortably sleep for a few hours.
So some basic conditions need to be excluded, and if you don't guide your juniors properly, they may not be able to identify these. So as a senior, always it's important that you ask these leading questions so that you avoid issues and tomorrow you are not taken to grief. As I'm fond of saying, medicine is from the beginning to the end an art of individualization. One size doesn't fit all. And though the textbooks say that XYZ is always applicable to ABC, there are always exceptions to the rule. Let's go to the next case. This is a 33-year-old primigravida. She's conceived on infertility treatment, has mild fetal growth restrictions. It's a late IUGR which has presented at 32 weeks. She was given conservative management, is doing well, color Doppler, CTG, everything is okay. And she at 37 weeks, her color Doppler is now showing a reduced end diastolic blood flow. CTG is still normal. Cervix is uninducible. Dr. Joyi Agarwal, madam, what would you like to do with her? Do you straight away want to do a elective cesarean section for her? Is this a really indicated cesarean section, or should you try and induce and then see how it goes?
Sir, I will immediately, the Bishop score is very poor. I will go for a cesarean section in this patient.
Okay. Dr.
I will
Elizabeth,
not induce this patient because...
Any difference of opinion?
Yes, sir. So this patient is having a reduced end diastolic flow with reduced baseline variability, but there is no decelerations. And with an unfavorable cervix, I would definitely like to give her induction of labor with a low threshold for cesarean section. I think
that is the key point here, that since the baby weight is just 2 kilos and currently this baby is compromised, the question in our minds should be, is this baby going to survive the duration of labor with an unfavorable cervix, which may be 10 hours, 12 hours? If the answer to that question is no, then probably we would lean on the side of cesarean section. This is an indicated cesarean section. On the other hand, if we feel that the baby can survive the stress of labor, it's going to be a short labor lasting maybe 4 hours, 5 hours, and otherwise with continuous monitoring in our setup, we feel that we can immediately do a cesarean at the first sign of distress, then maybe we would think of inducing. Again, like I said, India is a country of great disparity. What is true in my situation where I practice may not be applicable to yours. You finally have to take that decision in consultation with the patient and her relatives. So here we have tried for a normal delivery, and unfortunately this patient has landed up with meconium. We are going to do a cesarean section. What is the difference between an emergency cesarean section, which is done in this situation, as compared to an elective cesarean, which is a planned surgery? Dr. Alka Agarwal, madam.
In the same case, or it's a different case?
It's the same case. But we are comparing and contrasting. If we were to do a cesarean electively in this patient, how would it be different from an emergency cesarean section which is done for distress and thick meconium in the middle of an induction?
Yes, we have to keep our patient and only on fluids, and she should not be given soft. She should not be given any solids for patient. And we have to give injection amiset, and antibiotic should be given, and this patient can develop infection, and because if she is eating and she's drinking, then Mendelssohn syndrome, she can go into Mendelssohn syndrome also. So we have to arrange anesthetist and pediatrician. We have to arrange, and because weight is 2 kg only, we have to arrange neonatologist, and we have to inform NICU also that this baby maybe we have to shift that baby to the NICU. So we have to be well staffed. And
so the entire idea is that the entire team has to be well drilled. They have to be ready. They have to be aware that this is a cesarean which is being done for a fetal growth restricted baby with distress. I can see Dr. Uma Pandey raising her hand couple of times. Yes, please, ma'am, go ahead.
I would say, I mean, this baby is growth restricted, so we need extra care for the baby. Even if we don't have the growth restricted baby, and if you want to differentiate between elective cesarean and emergency cesarean, that it has a hell lot of difference. Elective cesarean section you do during the day hours, you have a proper anesthetist, you have good staffing, the OT is available, and there are so many things. While when you do emergency, everything is hush-hush. Maybe the anesthetists are second years in our institution, or maybe maximum we would have third years. Even the residents, second years and third years. So all these cases would be done by a staff. Maybe they are too tired. Maybe the OT isn't clean enough. Maybe the baby hasn't been resuscitated. So therefore, if you are planning, yes, I would go ahead with elective CS. Might as well do it and done and dusted in the morning hours rather than leaving it for residents, I would say.
So I think this is very clearly brought out that a planned elective cesarean section is something which all of us are mentally prepared for. The entire team is ready for. Whereas when there is an emergency cesarean section for such a baby, often the neonatologists are not prepared. Maybe we have not even bothered to inform them that we have such a patient in labor. That's a basic problem which we don't communicate to our own colleagues, and then the blame game starts. This baby did not go home, or this baby was in ICU for a very long time. Isko respiratory distress ho gaya. The problem is we don't communicate with our colleagues. We don't bother to find out whether bed is available, whether the appropriate senior staff are available from the pediatrician side as well. We should be identifying these lacunae in our chain of command and addressing them at the highest priority. That is how we ensure that both the mother and baby have the least amount of morbidity and hopefully mortality as well. I'm not saying that I am superior to all of you, even I make these mistakes. We are all human. But the more people you have in the chain of command who look at these issues, the greater the likelihood that you will be able to identify this. Dr. Anupya, have you seen this document before? Have you seen this slide before? Are you aware what this is? This is the WHO surgical safety checklist. Do we use it in clinical practice?
For cesarean section?
For any surgery at all. Are you using it in clinical practice? I'm not sure her connectivity is good. Maybe she can't see the slide. Dr. Juhi Agarwal.
Yes, sir. This is now recently we have started using in our OT, and it's a very good checklist, and this will save you from all sort of medico-legal.
Absolutely right. So no matter what surgery you do, whether it's a simple cervical cerclage or it's a cesarean section or a Vardai mastectomy, this has to be the front page along with the consent. This is mandatory as part of your indoor papers. Please look at this. If you are not using it already, start using it in your clinical practice. Disseminate it to your colleagues and friends. Educate your juniors about it. This covers everything in one single sheet. It's a standardized form. It's available from WHO. You can adapt it to your own institution and start using it because it covers everything that is necessary from medico-legal point of view. And tomorrow this might save one of us, I should say, not you, one of us from litigation and problems later on. If you have not read this book by Dr. Atul Gawande, I highly recommend this to you. It's called the Checklist Manifesto. He's a cardiac surgeon from the US, a person of Indian origin, and he's one of the people who is very much well read and well documented talking about surgical safety and checklists. We'll do one last case, Dr. Geeta Sinha, with your permission, and then we'll close this panel. This is a standard case. This lady is presenting at 34 weeks with signs and symptoms of preeclampsia. BP is 180 by 120. She has anasarca, administered labetalol. While you were seeing her, she had a generalized tonic-clonic convulsion. Baby weight is 1.750 kg. Let's bring...
Interactive panel, so please continue.
Yes, ma'am. Let's bring Dr. Ruchita Sinha back into the discussion, ma'am. This is no marks for guessing that this is an eclamptic. The problem is that right now she is only 34 weeks and this baby is very small. What should we do?
So we have to first see the general condition of the patient.
Correct. So ABC is first. Airway breathing circulation has to be stabilized. Then you will give her an anticonvulsant.
Yeah, then saturation monitoring, if she is developing pulmonary edema or not. Then the magnesium sulfate should be continued. We have to give her antihypertensives as BP is very high, 180 is too high. And the baby is IUGR. We'll check the presentation, then the Likert around, and we do a PV and Bishop scoring. So 34 weeks is the baby has attained maturity. And I think we will assess the Bishop score, and if it is low, we will give her a short trial of 4 to 6 hours. If she delivers, or we can extend even up to, some papers have shown even 12 hours is good enough. We can give to a eclamptic patient, and we will give her a benefit of trying a vaginal delivery.
Okay, I said there are some important points that you covered there. That first, we need to stabilize the patient. Second, we need to give her antihypertensive. She's already been started on labetalol, but probably oral labetalol may not work so well. If you have access to IV labetalol in your setup, it is highly recommended. It can be life-saving for a patient, prevents intracranial bleeds, brings the blood pressure down very quickly. As far as anti-epileptics are concerned, I would like someone else to comment. Dr. Anupriya, what is your choice of anticonvulsant in this patient who is an eclamptic?
So actually, I usually don't use anticonvulsant.
Okay. What do you use then, ma'am?
So I use labetalol, Magsulf. Okay. And so if there is convulsion, I will use Compose, IV Compose.
Okay,
IV Compose I give, sir.
Okay, Dr. Uma Pandey, any difference of opinion?
I think she mentioned magnesium sulfate, and I think
she did, but then she said that Compose is her agent of choice.
We don't use it Compose anymore. We used to use it when I was very little. Not anymore. Our drug, Ramban, is magnesium sulfate.
You still look little, but then that was a long time ago.
But when she is in convulsion, I have to use Compose.
नहीं मैडम, आप मैग्नीशियम सल्फेट करके देखिए, एकदम ठीक कर देता है. कुछ नहीं होता है उसके बाद. हम लोग तो बराबर उसी को यूज करते आ रहे हैं जब से हम लोग पढ़ते आ रहे हैं. प्लीज आप
we are using, but even after there is convulsion after magnesium sulfate, we have to give.
Then you add further 2 grams of magnesium sulfate, and then it settles.
Okay, I'm going to ask Dr. Alka Agarwal to comment on the WHO recommendation for anticonvulsants for eclampsia.
Yes.
Magnesium sulfate is the drug of choice.
Yes, and how do you administer it, madam?
There are 2 regimes, IV regime and Pritchard.
Yes, so there is
IV regime
and there is Pritchard. Which do you prefer?
If patient is undergoing LSCS, then IV regime is started, or if she is otherwise in preeclamptic toxemia, I prefer Pritchard. Severe preeclamptic toxemia, I prefer Pritchard.
Okay.
Intramuscular injection of magnesium sulfate.
So the key here is that both of them give the same doses of magnesium sulfate. One is an IM regimen, which we used to use in the good old days, or like Dr. Uma Pandey says, when I was little. And we have now, most of us, transitioned to the IV regimen, because anyway you're going to put two large IV cannulas. There is much better control with convulsions if you give IV. Also, the skin staining and abscess formation, which happens with the intramuscular Pritchard regimen, is more or less negated if you use the IV regimen, which is given by Juspan. The loading dose you can see is clearly 5 grams followed by 1 gram per hour, and you continue it for 24 hours after the last convulsion or delivery. I hope this message is going out to everybody that today in 2020, even after 30 to 40 years, all the research which has been done, all of the guidelines which have come, still undisputed champion is still magnesium sulfate. Whether you use 25% or whether you use 50%, please prefer magnesium sulfate. If you are in a primary healthcare or a Gaon situation, at least keep the intramuscular dose one shot before you refer the patient to a tertiary care center. That is going to be life-saving for her. Please remember that compost is no longer preferred today. It used to be used once upon a time when Krishna Menon regime or Lytic cocktail was used as a safer alternative, but today it is proven beyond all doubt that magnesium sulfate is the agent of choice. Cochrane says so, WHO also says so. Now you're doing a cesarean section for a woman who has had convulsions. She has now been stabilized. You're going to deliver this baby at 34 weeks because the cervix is unfavorable. Even if you were to induce her, the duration of labor would be too long, and with the stress of labor, she might convulse again. So for the sake of discussion, we are proceeding directly to the surgical pitfalls that happen if we don't anticipate complications during this cesarean. Not all cesarean sections are equal. Dr. Juhi Agarwal ma'am, how would you like to tackle this particular cesarean section? Is it different from a routine cesarean?
Yeah, definitely, sir. Since the patient is having a eclamptic fit,
and she's only 34 weeks.
And I would like to have all the investigations beforehand so that my anesthetist may be aware about all the associated complications which can happen in this patient since she is a case of eclampsia. So I would like to know her renal function. I would like to know her all the blood investigations like platelets, particularly LDH, everything I would like to know, and that will decide a route of anesthesia first of all. Because if she is having some platelet deficiency, she will not be operated in spinal. Of course, they will give a general anesthesia and then she will be operated on. And of course, I would like to anticipate postpartum hemorrhages in this patient again. So definitely, I would like to give oxytocin in higher doses, and also fluid restriction is required in postpartum care is also very important. Because since this is a compartmentalized syndrome in which there is fluid shift from intravascular to extravascular shift is there, and immediately after postpartum period, there is risk of developing pulmonary edema and other complications. So I will be very vigilant in managing, and definitely my intensivist and such patients are to be kept in obstetric ICU care where an CVP line could be maintained.
So this is definitely a patient who is going to require an HDO setup post-delivery, and if you don't have such facilities, then at least she should be monitored in an ICU for 24 to 48 hours immediate post-cesarean. But during the cesarean itself, Dr. Ruchita Sinha ma'am, what would be your choice of incision, both for the abdomen as well as for the uterus? This is a preterm baby. This is 34 weeks. Baby weight is 1.750 kg. It's a small baby. Probably it's a poorly formed lower uterine segment. How would you tackle this particular cesarean and bring the baby out with minimum of trauma?
So if you want to avoid trauma, then in that case, classical cesarean section would be the best. Okay. Or a little higher, a lower cesarean section, we can definitely do that. And since she is a primary gravida, I will prefer a little bit higher lower segment cesarean section.
Okay. So since the lower segment is poorly formed, you may need to resort to what is called as an inverted T incision or a classical cesarean section. incision. Make your access wide enough to ensure that the baby can be delivered without any trauma. Sometimes you might find that if the patient has already had a rupture of membranes, then there is very little liquor around the baby and delivery becomes especially more difficult. Yes, Dr. Umar?
We can use forceps in such case.
Yeah, you can use an instrument. You can use a vectis or an obstetric forceps so that the baby comes out in that cage and there is less cranial trauma. Yes, Dr. Uma Pandey?
Yes, I just wanted to say that a woman is 38 weeks, the pregnant mother, and very rarely we need to use the classical incision.
True. Agree.
And moreover, if you do classical incision, you are kind of spoiling the woman's obstetrical history, because if she goes for next cesarean or next labor,
agreed,
you will be very scared of her laboring normally.
So it's something which you can only decide on table once you've opened and you assess the lower segment. If you find that you cannot get an adequate access, then you may need an inverted T or a J-shaped or a classical. You don't start the cesarean in mind that I'm going to do a classical. Correct. It's something which you assess on table and then you decide.
Yes.
Again,
mostly we can manage with an inverted T or a J shape, sir.
Yes, but then that has to be documented again in the notes. That has to be there in the patient's discharge card, not that you have done an inverted T and the patient has gone home without documentation. Next pregnancy, she ruptures.
Yeah.
That should not happen.
The anesthesia, I wanted to just add a point, sir. The graded epidural will be the best actually for an eclamptic woman, unless she has coagulation abnormalities and a low platelet.
True.
Compared to a spinal, it would be better for her to go in for a graded.
Agreed.
Most of us like to still give regional anesthesia because we are afraid that the patient may not come out of general anesthesia. She may have respiratory depression, especially if there isn't enough time given between the last dose of magnesium sulfate and your incision. Those incidences are much higher, and then your baby is fine. Baby is in the NICU, relatives are all happy, and then you have to face their questions regarding why the patient is still in ICU, why she is on ventilator, and so on and so forth. It becomes difficult to tackle at that particular point of time. So we've talked about a lot of issues which are surrounding ICU, perinatal morbidity, mortality, and you can see here that eclampsia, postpartum hemorrhage are the biggest killers even today. Timely detection and the pillars of obstetric care are all important in this particular patients. I think we are at the end of our time. Should we stop here?
We could discuss.
Sir, okay, there is a very important message in this case 5, sir. Please discuss it fast.
Okay, we'll do one more case. This is a 30-year-old lady. She's conceived on treatment, abnormal GTT at 30 weeks. This has partly been discussed by Dr. Parag Beniwale during his talk. And she's at 38 weeks now. She is well controlled on insulin. Do we wait for normal labor? If we don't wait, do we induce her? If we don't induce, do we do a cesarean section? Since Dr. Juhi Agarwal wants to tackle this, we are going to let her have the first dibs on.
Sir, since this patient is on insulin,
yes.
So we can plan her induction before 38 weeks.
Okay.
And we can ensure her safe delivery. Not cesarean section. Talking about cesarean section, of course, we will go for ultrasound parameters. We'll go by headlock. We'll see for fetal weight. We will anticipate, that shoulder dystocia and other complication which a macrosomic baby may have. So definitely, once we anticipate all those things, we will go for elective section, I think. But if at all you have ruled out all those things, we will do induction.
Okay. Anybody with a difference of opinion? Dr. Elizabeth has been very quiet for a long time. I think she must be seeing the maximum incidence of diabetics anywhere in this country.
Yes, sir. Kerala is the biggest capital of diabetes as far as India is concerned.
Please tell us, what is your approach?
Yes. So there are no clear-cut guidelines, sir. Dr. Beniwale also said that regarding induction, each organization, the NICE, the ACOG, the FOX, everybody has their own guidelines. But I think for consensus sake, we can say that GDM patient on diet can definitely be taken till 40 weeks. This patient, GDM on insulin, I think between 38, if she is well controlled, she can be taken between 38 to 39 weeks of pregnancy. So up to 39 weeks, she can be safely taken with monitoring of the fetal well-being. If her cervix is favorable at 39 weeks, she can be induced. The role of ultrasound in determining the estimated fetal weight is highly erroneous as far as GDM women are concerned, because it actually is augmented. The miscalculation is augmented or accentuated in GDM women. So you may overestimate the fetal weight and unnecessarily land up in doing a cesarean section. And also evidence is actually increasing that cesarean section per se is not going to eliminate the risk of shoulder dystocia nor birth trauma because of that. So I think we need to take an individualized risk assessment approach, wherein we'll have to look at the Bishop score, the clinical parameters, whether her sugars are well controlled, and then take a final call discussing with her all the parameters, explaining to her the three key parameters that sugar control, the estimated fetal weight, can be erroneous, and that brachial plexus injury or shoulder dystocia cannot be totally eliminated by a cesarean section. Give her a choice to decide what approach that you would want to take regarding the mode of delivery. I think that would be the take to discuss with her, get a good informed consent, which is non-directional, and an informed consent.
Dr. Ruchita Sinha, ma'am, anything else you would like to add here?
So I agree with Madam. Sir,
Okay.
I would like to induce her because she is conceived by infertility treatment. Second thing is she is on insulin therapy. And regarding this macrosomia, there are two other factors also by which we can predict if it is a macrosomic fetus or not. The ratio of abdominal circumference to biparietal diameter. If it abdominal diameter to biparietal diameter, if it is greater than 2.6, by that we can predict. And the other method is the calculation of abdominal circumference. If it is greater than 36, then of course the predictive value is quite high of both these methods. So we can predict and like save the mother from a traumatic vaginal delivery.
All right. So I think a lot of important issues have been highlighted by all our panelists here. And what I can tell you is that all three approaches, waiting for spontaneous labor, elective, cesarean, and induction of labor, all three of them are correct. The only question is which guideline you follow and what is the exact situation in the patient who is in front of you. If you look at the American College guidelines, which were released in February of 2018, they usually classify patients into three categories. And what they have found is that if you have a patient who has good glycemic control, what they call A1 GDM, you can manage expectantly up to 41 weeks, same as the RCOG guideline for induction of labor in women who are post dates. Women who are well controlled with simple diet and exercise are called as A1 GDM. This does not apply to this patient, obviously, who is on insulin. I've just put this slide here for the sake of completion of the discussion so that there is no confusion. Next is a woman who is well controlled and she is on insulin or OHAs. What is recommended is that these patients should be delivered between 39 to 40 weeks, and that is why the case is about 38 weeks. You can wait for up to 1 week, assuming all the other parameters are normal. If you have a non-reactive CTG, or you have a lowered kick count, then you have a low threshold, and please go ahead and terminate the patient. If your Bishop is good, you can try for a vaginal delivery if there is nothing to preclude vaginal delivery. If there is even the slightest indication that you are going to land up in trouble, like Dr. Ruchita Sinha rightly pointed out, then please be liberal and go ahead with cesarean section, because nobody will forgive you if you land up with a shoulder dystocia or a battered baby. And the last, of course, is women who are uncontrolled, even with insulin, or poorly controlled, non-compliant. You can even plan delivery before 37 weeks, because sometimes these babies do much better outside in an NICU as compared to the hostile in utero environment. We've already tackled the question of whether ultrasound estimates are good and accurate. You will find that this meta-analysis showed that only 22% of babies who were ultrasound diagnosed as macrosomic were actually macrosomic at term. We'll close this panel discussion by saying that a physician needs to have some faith in himself to be of use in this world. We had some fantastic, interactive, engaging discussion on a wide variety of cases. I'd like to thank all of my eminent panelists for giving us their time, their expertise, and sharing their views with us. Before we close, I'd just like to invite all of them to give us one simple take-home message. We'll start with Dr. Elizabeth.
Can I just add one more point to the GDM thing before I give my final comments?
Yes, yes.
So the ongoing trial, that the GenExcel trial will actually shed light on whether the expectant management should be between 38 to 39 weeks. So I think we should wait for that. Let me conclude by saying a big thanks to Dr. Pratik and to the Jharkhand societies for making me part of this wonderful panel. I enjoyed thoroughly being with all of you today. And to give the valid take-home message, I want to take the words of Michael Robson, actually, who brought in the 10-group classification. So he said that the cesarean section rates, the thought about cesarean section rates, it's not about it being too high or too low. It should be about whether it was appropriate or not, taking into consideration all the relevant clinical information. I think that is what we should take to us. And the main important aspect of reducing cesarean section rates should start with one, that we have good audits about our labor room methodology. Second, the antenatal classes. Third, the adequate labor analgesia. And I wanted to raise one more point about the remuneration for vaginal birth and cesarean section for the doctor to be the same, so that there will not be a band baja on our head saying that we are doing more cesarean sections in order to make more money. So I think finally, let me end by saying that obstetrics is definitely a bag of surprises. Expect the unexpected is the norm, but still, by bringing in a team effort, a team practice, and not an individualized practice, maybe we'll be able to reduce the cesarean section rates in the future.
Thank you so much for your valuable inputs, ma'am. Dr. Alka Agarwal, ma'am. Closing comments from you.
Yes, thank you, Dr. Pratik and MPOPS and Jharkhand Society for giving me this wonderful opportunity to be a panelist. And my take-home message is that we should document whatever we are giving counseling to our patient, and counseling should be with the patient, with the patient's husband, with the patient's mother-in-law, and that counseling should be recorded on paper, as well as if we do video recording of the counseling, that will help us in future litigations. So documentation of this and consent is very necessary. Thank you, sir.
Thank you so much, ma'am. There are 650 viewers logged in who are waiting to listen to Dr. Uma Pandey's words of wisdom.
Thank you. I think Dr. Elizabeth said so eloquently. I was so impressed by the way she described. I just loved it. Dr. Elizabeth. It was wonderful.
Thank you so much, ma'am.
Now I'm just going to say that thanks to Dr. Pratik Tambe, obviously, and Bharat Serum Spectra. Regarding reducing cesarean rate, when I joined, it was being discussed at that moment of time. I think a month ago, we had a webinar in which we had an international author, speaker, who presented his data that if they did not offer women cesarean section when they requested, what was the mental agony, what was the mental distress, anxiety, depression, and all those kind of things they had studied. And it showed that if you were just too pushy and told the women, no CS, you are going to deliver vaginally, and that's the only option you have, that has led to lots of mental complications. Therefore, we should be very kind to our woman and think that she is in pain. So maybe we should listen to her. So that is one thing. Second thing is that in BHU we always had this culture of having companion with the laboring mother. I would also encourage that in many other hospitals, having even if there is a sister. Husband is not allowed in India, I know that, but at least a sister sister-in-law, mom-in-law, anybody, would it really help? Third thing, if we did respectful maternity care. In India, what we do in our country, where I work in my institution also, then many a times we are rude to our patients. And अच्छा चुप रहो, अच्छा तुम्हें कुछ नहीं हो रहा है, कोई दर्द नहीं हो रहा, चुप रहो, हमको अपना काम करने दो, हमें बच्चे की धड़कन सुनने दो, नहीं तुम्हें कोई दर्द नहीं हो रहा, मुझे तुम्हारी जांच करने दो. दैट्स नॉट राइट, दैट्स नॉट राइट. उसको थोड़ा बदलना पड़ेगा. वो उनको अपने आप को डॉक्टर को पेशेंट के बेड पे रखना होगा और पेशेंट को इधर रखना होगा. So these three things I would like to say. Thank you.
Thank you. I think the RCOG calls it being sensitive and non-judgmental, if I may be a little more eloquent. Dr. Juhi Agarwal, ma'am.
Thank you so much. Thank you all the panelists. Thank you, Dr. Pratik. Probably Corona days have made this possible. We would not have done such webinars and I would not have been able to meet such wonderful people around here. So thank you so much. It's high time that we should start doing Robson's criteria and entering our records accordingly so that we as a part of FOGSI and we as a FOGSIan may help FOGSI to audit not globally but at least nationally so that we can just put data on face of these reporters and also these politicians that yes, we are right, we are not actually doing cesarean section for the sake of just doing it. And of course, I agree, Dr. Elizabeth, that the remuneration for cesarean section and normal delivery should be same because that is one thing which bothers the patient a lot. वो cesarean इसलिए करते हैं क्योंकि उनको ज़्यादा पैसे मिलते हैं. That is very commonly said thing. So thank you so much.
हम लोग नहीं कराते हैं जब पेशेंट, हम तो गवर्नमेंट में हैं तो हम लोग कहते हैं ठीक है मरीज लेके जाइए, घर जाइए.
नहीं तो गवर्नमेंट में
we are still on air, Dr. Uma Pandey. We are still on air. We are still live.
We receive many patients because अरे वो हम प्राइवेट में गए थे ना, वहाँ पे तो हमारा सिजेरियन कर देते इसलिए we came here. So it's like that. So that notion should get off from the society.
Yes, I agree.
Thank you. Dr. Ruchita Sinha, ma'am, any closing remarks from you, ma'am?
First of all, I'd like to thank you so much for inviting me to this panel discussion. It was a wonderful panel discussion. And the take-home messages, I think auditing is very important and we should always analyze ourselves at what we can reduce cesarean section and teaching our juniors and not letting the art of assisted vaginal delivery, especially the good old outlet forceps and the ventouse, we should not let the art die and always impart knowledge to our juniors. So, and by that only we can decrease the cesarean section rate.
Thank you, ma'am. Thank you so much. Dr. Anupriya Pankaj, any closing remarks from you, ma'am?
Yeah, I think, sir, we should give a fair trial of labor for all the patient and if the condition applies, we should give the induction for labor. And we should not go for the easy way out and cesarean section due to maternal request. And we should be more.
Thank you so much, ma'am. I think that is very well put. A lot of good key take-home messages from all our esteemed faculty. I'd like to close by placing on record my gratitude to our MOGS office bearers, Dr. Nandita Palchetkar, Dr. Arun Nayak, my zonal coordinator, Dr. Kedar Gandla, our chairpersons, all of them did a fantastic job. Our two speakers were simply out of the world. I think a lot of congratulatory messages from everybody. And I'd like to hand over to Dr. Geeta Sinha for the official vote of thanks. Before I do that, I must thank the backbone, Science Integra, Meenal, Subbu, Seshan, Shrimon, all of you do a fantastic job. And our academic partners for today, Bharat Serums and Vaccines. Thank you for the platform which you have given us.
For the wonderful panel.
It was a very good, interactive and very interesting panel. Those who are practicing Obstan Gynae, really they have enjoyed very well. So thank you for all the panelists and special thanks to Dr. Pratik Kambe, who is the sole organizer and convener and moderator of this panel discussion and this webinar. So my thanks to MOGS Endocrinology Committee, Jharkhand Society, and all the doctors who are participated in this webinar. My thanks to all dignitaries, a special thanks to our chief guest, Dr. Mandakini Meg, who has accepted our invitation and spare her precious time for this high risk pregnancy webinar. My thanks to our respectable chairpersons that who chairs this session. My thanks to Dr. Rajendra Pardesi, Dr. Maya Verma, Dr. Vinita Sahai, Dr. Kaushik, who was not present but still he has given the consent for this webinar to chair the session. My thanks to Kavita Priya. My special thanks to our very prestigious, eminent and vibrant speaker, Dr. P.K. Shah, Dr. Parag Biniwala. They enlightened our knowledge about RH isomerization and current management of GDM. My thanks to all panelists, Dr. Ruchita Sinha, Dr. Anupriya Pankaj, Dr. Neeta Sahai, Dr. Neetu Sahai, Dr. Alka Agrawal, Dr. Juhi Agrawal, Dr. Uma Pandey, Dr. Elizabeth Jacob, and Dr. Meera Lakhtakia. This is a very
useful.
This is really, I thanks to Dr. Pratik, special thanks to Dr. Pratik, and thanks to Minan, thanks to Bharat Serum Vaccine Limited, and my wholehearted thanks to Dr. Pratik who made me as a second convener, which was I never expected. So thank you, sir. Thank you. Thank you. Thank you, the whole team, and thank you for this webinar, informative webinar. Thank you.
Thank you, everybody. Take care. Stay safe. Bye for now.